Okay. So we've got the rounded lateral meniscus, and we've got the more sort of lazy curved medial meniscus. These menisci are actually made of fibrocartilage, and fibrocartilage in the body is distributed in terms of the fibrocartilaginous discs, like the disc you get in symphysis pubis, in the acromioclavicular joint, at the annular margins of the discs, annulus fibrosus. And the biggest fibrocartilage is, of course, the menisci of the knee joint. You've got the acetabular labrum and you've got the glenoid labrum. They're all examples of fibrocartilage. All these fibrocartilage structures are low signal intensity on MR, and they appear echogenic on ultrasound. So if you try and evaluate the meniscus with ultrasound, you can see parts of it. You will notice that the medial and the lateral menisci are slightly echogenic. Similarly, the glenoid labrum, when you see that on ultrasound, is a bit echogenic. But all these structures on MR assessment are of low signal intensity. They work as big swabs which distribute the synovial fluid within the knee joint, and they also provide some degree of cushioning to the tibiofemoral articular surfaces. This particular drawing is really important because it allows you to remember the arrangement of structures on the upper tibial eminence. So this drawing has been made as if you are looking from top down into the knee joint. The femur has been removed. That's the front. That's the back. That's the lateral side. So it's a right knee, and that's the medial side. And we see that on the central tibial eminence, you've got the anterior horn of the medial meniscus as the most anterior structure. Then you've got the tibial attachment of the anterior cruciate ligament. Then you've got the anterior horn of the lateral meniscus. Then you've got the posterior horn of the lateral meniscus. Then you've got the posterior horn of the medial meniscus, and most posterior, you've got the tibial attachment of the posterior cruciate ligament. So M, A, L, P, mol MP. Medial meniscus, anterior horn, anterior cruciate ligament, tibial attachment, anterior horn of lateral, posterior horn of medial, and posterior cruciate ligament. That's one mnemonic which is quite useful to remember the arrangement of structures on the upper tibia. Now I've lost my ability to move the mouse.
I can see your mouse moving.
I can see my mouse. I can't move to the next slide. So that's what I did. Let me just.
So maybe you can try to exit the PowerPoint and come back in. Stop sharing. Stop share and come out of it. Yes.
So That's the important mnemonic that we all should remember. The meniscus, as we've seen, it is a semi-lunar shaped structure. And in the sagittal imaging, it gives appearance of a bow tie. So if you draw, this is the same image when you're looking at the meniscus from the top end. And if you draw a sagittal image going through the peripheral part of the meniscus, we can see the same structure here. So that's the anterior, that's the posterior, and we can see that the meniscus low signal intensity is shaped like a bow tie. As you move further towards the central side of the knee, you will see the bow tie shape still continuing. We've got a larger posterior horn and we've got a smaller anterior horn. That's the classical appearance of a normal medial meniscus. Going further towards the central side of the knee joint, now we've come across a place where the two segments of the bow tie appear to have been separated by the space present between the meniscus. If you do not get to see the bow tie on at least two consecutive slices, then you know that you are dealing with a possible meniscal tear. That is, the meniscal tissue has been significantly attenuated and there is a degenerative tear present. More about that later. A couple of pitfalls which you need to be aware of. The anterior horn of lateral meniscus, where it is attached to the tibia, can normally show a lot of feathery appearance. That feathery appearance is because the tibial attachment of the anterior cruciate ligament shares an origin with this structure. And where these ligament fibers are interdigitating, then it can become this feathery appearance like that. I've seen that people who have started reporting knee MRs, they tend to call this as a possible tear. A tear of the anterior horn of lateral meniscus can happen, but when it happens, it almost always tends to communicate with the body of the lateral meniscus. So if you just see what looks like a tear of the anterior horn of lateral meniscus, I would undercall that and would not necessarily call it as a tear. The second normal variant that you need to be aware of, or a pitfall of imaging, I should say, is the phenomena of meniscal flounce. That's a normal finding, and you can tend to see it in both medial and the lateral menisci. And the meniscus just looks a little wavy in appearance and contour. So that's a normal finding. The third pitfall is the presence of a transverse ligament. So I'm going to just follow this patient's scan. We've got the meniscal tissue here. And as we go towards the central side, this is the anterior horn of the meniscus, and we can see that there is a structure which tends to travel all the way up, where it then connects with the anterior horn of lateral meniscus. So follow that again. This is the anterior horn of medial meniscus. We're traveling towards the lateral side, outer side, and we can see that there is this low signal intensity structure. And if you just look at the single image here, you can suspect that there is a tear of the anterior horn of medial meniscus. But if you follow it, you see that it actually gets communicated with the meniscus. And in the axial image, it is this structure which causes this confusion. And that's a normal anterior transverse ligament. It's not a tear. Laterally, we have got the attachment of the popliteus tendon. So the popliteus muscle arises from the back of the upper tibia, and then it travels posterolaterally to get attached to the popliteus groove present on the lateral femoral condyle. This is intimately related to the lateral collateral ligament and to the tendon of biceps femoris, where they are attached to the head of the fibula, the conjoint tendon. Peripherally, in the meniscal tissues, you've got the meniscocapsular area. So that's the medial meniscus, and we can see that it is quite intimately related to the medial collateral ligament. If there is a separation between the two, we know that that's not a normal phenomena. On the lateral side, you've got more of a normal space. There are meniscotibial and meniscofemoral struts of connective tissue which connect the body of lateral meniscus with the ipsilateral femoral and tibial condyles. Posterior horn of the lateral meniscus is intimately related to this low signal intensity structure, which is the popliteus tendon, which I identified earlier for you. Whereas on the medial side, we've got fibrofatty tissue at the back of the posterior horn of medial meniscus. So notice that the posterior horn of lateral meniscus is different from posterior horn of medial meniscus. Here we've got the popliteus tendon. Here we've just got some fibrofatty connective tissue. Another important factor which we need to remember is that the menisci, although they are fibrocartilage, they do have blood vessels in the peripheral 1/3 of the meniscal tissue. Because of the presence of these blood vessels, the signal intensity in the outer 1/3 of the meniscus can be a little greater, and that's a normal finding. The low signal intensity meniscus, whenever you see an increased signal intensity, the relatively inexperienced radiologists, they tend to begin to think about degenerative change or a possible meniscal tear. But remember, in the young patients in particular, you will come across some increased signal intensity in the meniscal tissue, which is because of normal vascularity. Now, clinically speaking, when you're talking about patients with meniscal tears, you've got patients who present with pain in the knee joint, symptoms of knee joint giving way, symptoms of locking of knee, clicking when they walk or they move, and limping. They can or they may or may not be soft tissue swelling in the knee joint. Posterior horn of either meniscus should never be smaller than the anterior horn. So in case of medial meniscus, we know that the posterior horn is larger. And in case of lateral meniscus, it is of equal size to the anterior horn. If the posterior horn of any meniscus is smaller than the anterior horn, then we've got a problem. That means that there is a tear. The criteria of diagnosing a meniscal tear, you have to have a high signal intensity which reaches the articular surface of the meniscus on at least 2 consecutive slices. This is the so-called 2-slice touch rule, and its positive predictive value is almost 100%. So if you've got a clearly increased signal intensity present in the meniscus and it reaches a articular surface, then that is a very good indication that we're dealing with a tear. So normal meniscus is of low signal intensity. Once you've got a tear, it's of a bright signal intensity, and we've said that it has to reach an articular surface, and that would make it as a tear. You can have bright signal intensity which does not touch the articular surface, either lower or upper. It is just contained within the meniscus. These are examples of medial meniscus. Notice the large posterior horn and the fibular head. You can just about see it there. So that's the medial meniscus, and it's got bright signal intensity. It's not low signal like the anterior horn is, but this bright signal does not reach the upper or the lower margins of the meniscus, and that's a mucoid degeneration. The second criteria is that you end up with a meniscus which has an abnormal shape. It has lost its bow tie, or it has got a missing segment of the meniscal tissue. The tears can be of longitudinal variety or a horizontal cleavage variety. A horizontal tear would divide the meniscal tissue into an upper and a lower half, whereas a longitudinal tear will divide it longitudinally along the length of the meniscus, longitudinal axis of the meniscus. Here is an example of an undersurface oblique shaped tear. So you've got a coronal image and you've got a sagittal image. That's the medial meniscus again. We've got the iliotibial band attached on the lateral side. And we can see that there is a bright signal intensity which connects the inferior meniscal surface. And in the sagittal image, it also connects with the inferior meniscal surface. And you have to have that in at least 2 consecutive slices. And that's a good example of a horizontal cleavage tear. Notice that this tear, it divides the knee into an upper and a lower half. So that's the example of a horizontal cleavage tear. This type of tear is more commonly seen in patients with degenerative knee joints. So patients of an elderly age group beyond 45, I would say. The same sort of horizontal cleavage tear can have a bit of a longitudinal component in it, in which case it will end up being called as an oblique shaped tear. So an oblique tear is not exactly horizontal like that, but it's showing an oblique configuration. So it's a mix of horizontal and a longitudinal component of a tear. That's a left knee joint. So you've got the medial collateral ligament here. We've got the iliotibial band here. The medial meniscus shows this bright signal intensity going through the body of the medial meniscus. And in the sagittal imaging, it is present over the anterior horn, and that's an oblique shaped tear. A vertical tear is perpendicular to the tibial plateau. It goes along the longitudinal axis of the meniscus, parallel to the circumference of the meniscus. So instead of going in this direction, it's going in this direction. And a longitudinal tear is usually seen in patients who have got traumatic tears. So these are younger patients, and they are physically active athletes, your football players, your basketball players, who are otherwise healthy and fit, and they end up with this type of a tear. That's a nice example. This is an axial image, the same sort of image that we saw at the start of my talk when we were trying to remember the mnemonic, which describes the structure arrangement on the upper tibia. That's the front, that's the back. That's the medial side, that's the lateral side. And the medial meniscus here shows this longitudinal configuration of a tear. So this, by definition, is present along the longitudinal axis of the meniscus. And if you look at the coronal imaging, it has divided the meniscus not into an upper and a lower half, but into a medial and a lateral half. So that's the difference between a longitudinal tear and a horizontal tear. Similarly, in sagittal imaging, it is not dividing the meniscal tissue into an upper and a lower half, but into an anterior and a posterior half. So that tells you that we're dealing with a longitudinal tear. And this is the type of tear which, as I've said, tends to happen in younger, athletically active patients. Another point to note is that the longitudinal tear usually happens in the vascular segment of the meniscus. And what does that mean? Why is that important? It is important because that means that this type of a meniscus can heal relatively better. Because there's blood supply there, it will be able to repair itself with granulation tissue, and there is some prognostic importance to try and understand that these meniscal tears can be treated successfully. The third type of a tear is called a radial tear. A radial tear happens in the central free edge of the meniscus. It can result in articular surfaces getting in contact with each other because the tear is happening at the area of the meniscus where the bones are quite close to each other. It tends to result in cartilage damage at the adjacent surfaces, and there is a degenerative change present in the knee joint. These tears are small in size, but they can be surprisingly symptomatic. So important to see them, these small radial tears. If they're not recognized early enough with the continued weight bearing and use, they can very quickly increase in size, and then they cause a lot of problem. Imagine that you're looking at the top end of the tibial condyle, and you can see the C-shaped meniscus here. And when you have a radial tear going like that, and you did a sagittal imaging, then you will be able to see the anterior horn of the meniscus quite nicely. But where the posterior horn should have been, you won't see anything. So that's a ghost meniscus, and that means that there is a radial tear. So if you had a sagittal imaging here, that will be completely normal with anterior and posterior horns. A sagittal image here would have the bow tie, but right through the tear, you'll only get the front and not the back. If you have a tear going through the central part of the meniscus, then this on the coronal imaging will have the same sort of an appearance, that you will have the peripheral segment of the meniscus indicated by this light blue color area. And then the central darker area would be where the tear has happened. You won't see that. So the radial tear, depending on where exactly they are and how you are choosing to image them, they can look a bit different. If you did that in the sagittal plane, you will have the normal anterior horn, then you'll have the missing meniscal tissue, and then you'll have the normal posterior horn. So it should have been a bow tie here, but you've got the meniscal tissue only at the front and at the back, and here it's a missing meniscal tear. Radial tears, of course, can happen in a slightly oblique fashion like that. And if you did that, you will see in this example, this is a lateral meniscus. We've got a tear here. And then in the sagittal imaging, instead of the bow tie, we can see a blunted anterior half of the meniscus with a tear here and the straight-edged posterior half of the meniscal tissue. Here in this case, we can see in the coronal imaging, there is a tear here in the medial meniscus, but concentrate on the lateral meniscus. We can see that there is a central edge of the meniscal tissue which is missing. And when you do a sagittal imaging here, we can see that there is a sharp radial tear present right at the front, junction of the anterior horn and body of lateral meniscus. Depending on exactly where the meniscal tear is, you can have what is called the marching cleft sign. So imagine a meniscal tissue with a oblique shaped radial tear. So if you did a sagittal imaging here, we will have this sort of an appearance, lots of normal meniscal tissue, and then the radial tear at the back. Then the next sagittal imaging, the cleft would have moved slightly more anterior. And the next sagittal image towards the central part of the knee joint, it would have moved still further. So because of the shape of the radial tear, consecutive sagittal images show that the cleft marches progressively forwards. And that's not an unusual appearance when you're evaluating for a radial tear. And that's the marching cleft sign in actual live case. We can see that the sagittal image here shows the cleft present here, then further back, and then further back. So that's a marching cleft sign for a radial tear. A few points to remember in terms of identifying meniscal tears. Medial meniscal tears are more common than lateral. Lateral meniscus has got some sort of a protection because the popliteus tendon is attaching to it. So whenever the meniscal tissue is getting caught between the moving lower femur and upper tibia, the popliteus can sort of pull it out of the harm's way, and therefore the lateral meniscal tear is relatively less common. It does happen, but medial meniscus tends to tear more commonly because it's relatively more immobile. Up to 80% will have some sort of an associated ligamentous tear. These could be the meniscofemoral and meniscotibial ligaments, or one of the cruciate or collateral ligament injuries. In cases of acute tear of anterior cruciate ligament, medial meniscus posterior on and the meniscocapsular area of the medial meniscus can be torn in up to 40 to 80% of cases, whereas a lateral meniscus tear tends to tear more commonly at the posterolateral corner. In cases of chronic anterior cruciate ligament insufficiency, patients who have had their ACL torn, but they have not chosen to get it repaired and are carrying on with an incompetent ACL, the incidence of a medial meniscal tear reaches almost 90%, because the knee joint is very floppy. It's moving all the time, particularly when they're coming down the stairs. And therefore, the meniscal tissue tends to get caught more commonly between the femur and the tibia. When you have multiligamentous injuries like injury to the anterior cruciate ligament and medial collateral ligament, because of the mechanism of injury, the pivot shift mechanism, the lateral meniscus tends to get affected more commonly, despite the protection that is offered by the popliteus tendon. The radial tear distribution tends to happen more commonly on the anterior horn of lateral meniscus. Then posterior horn of medial meniscus tends to get affected most commonly. That's very important. Remember what I told you about the degenerative horizontal shaped tears tends to divide the meniscus into an upper and a lower half. And it is these sorts of meniscal tears which, with the passage of time, will end up with a parameniscal cyst. Connective tissue of the meniscus, which is degenerate, tends to keep on leaking out, and you will end up with a parameniscal cyst. Why is it important to remember? Because sometimes, almost all the times, it is much more easy to see the parameniscal cyst. That's like an indication which tells you that something is not right. And then you look carefully at the meniscal tissue and you find a tear. You cannot have a big parameniscal cyst without a clearly defined meniscal tear. So look carefully and you will find one. And that's what I mean. It's very easy to see a tear present in the body of lateral meniscus by the presence of this big parameniscal cyst. That's the lateral meniscus, that's the iliotibial band, and we can see the cleft here, but then the big parameniscal cyst tends to highlight the area of meniscal degeneration. The longitudinal tears and the oblique tears, they are usually repaired. They can be repaired. I won't say usually, because you have to see who the patient is. In terms of elite athletes, this type of a tear at least has the potential of getting repaired, because they're present in a young person. The tear is present in the vascular segment of the meniscus, and it is important for those people to carry on with as much meniscal tissue because of what they do, and therefore they will be the candidates to have it repaired. The radial tear, the horizontal tear, and the complex shaped tears, they tend to get debridement or partial meniscectomies. The idea is to try and preserve as much meniscal tissue as you can, because there's no doubt that once patients lose their menisci, then their knee joints would have an early degree of degeneration. What about this term that we keep on hearing, which is the bucket handle tear? A bucket handle tear is a type of a longitudinal tear which tends to get bigger. So vertical longitudinal tear, 10% of meniscal tears can be the bucket handles, because they can eat up a huge amount of normal meniscal tissue, so you will end up with an absent bow tie sign. And once you have seen an absent bow tie, then you look carefully in the intercondylar notch or at the peripheral margins of the meniscus, and you will see a displaced meniscal fragment, either giving rise to a double cruciate ligament sign or a flipped meniscus sign. So longitudinal tear happens, and with the passage of time, it just gets bigger. So here's the meniscus, then you got a longitudinal tear, and then you got the displaced meniscal tissue going towards the central segment, and it can get curled up and just becomes a loose body inside the knee joint with an attenuated rest of the meniscus. Here's an example, coronal and a sagittal imaging of the right knee joint. That's the lateral side. We can see that the anterior horn of the lateral meniscus can be seen here. The medial meniscus is quite attenuated. Compare the body size of the anterior horn of lateral meniscus with the body of medial meniscus. And there is some low signal intensity tissue present in the intercondylar notch. And when you do a sagittal imaging, we can see that there is a big low signal intensity structure present in the intercondylar notch, giving rise to a double PCL sign. And that's a displaced meniscal fragment, which has come from the body of the medial meniscus, based on the pathophysiology, which I've explained schematically in those orange colored diagrams. If you have a bucket handle tear of the lateral meniscus, then you will end up with a double ACL sign. The horizontal or oblique meniscal degenerations or tears can be asymptomatic because they tend to happen in elderly patients. They have got some pains, but not too bad, and they can carry on. The radial, the vertical, the complex or displaced meniscal tears are usually symptomatic, and they would result in the clinical syndrome that we mentioned earlier in terms of painful locking, clicking knee joints. Of course, if the horizontal or oblique shaped meniscal tear is accompanied by injury to the collateral ligaments or pericapsular soft tissues or bone marrow edema, then they would have symptoms more readily with them. The displaced or a flap-shaped tear is the example of a tear when there is a meniscal tear present, which instead of traveling towards the intercondylar notch, it tends to flip underneath the meniscal body and can be present below or above the meniscal tissue. And here are the examples. So you've got the medial meniscus, which has got a markedly attenuated posterior horn and a very chunky anterior horn. I explained to you earlier that you can never have the situation in which the posterior horn of any meniscus is smaller than the anterior horn. So that clearly is not normal. And when you look carefully, you realize that there's actually not anterior horn by itself, but some of the meniscal tissue from here has flipped forwards and has resulted in this sort of double meniscal tissue present anteriorly, which you can see in the axial imaging here and in the coronal imaging there. So there's an abnormal meniscal tissue which is transferred from back to the front. It can be good exercise and good fun to try and look for the displaced meniscal fragment, which usually happens in the intercondylar notch. So we've got the right knee joint, lateral side is here, medial side is here. We can see that the body of medial meniscus is showing increased signal intensity, and it's smaller in size, and there is this displaced meniscal tissue, which is present in the intercondylar notch. Another example of displaced meniscal fragment, this time present in front of the anterior cruciate ligament on this side. Another example of displaced meniscal tissue in the intercondylar notch. It just looks like a big globular mass of fibrous tissue. And notice the absent and attenuated medial meniscus. You can have injuries to the peripheral aspect of the meniscus. I briefly touched upon this concept earlier. It is important for us radiologists to identify this injury because the arthroscopists will not see it. It's present on the peripheral side of the meniscus. It tends to happen in the red zone, the vascular segment of the meniscus, and therefore it has the potential to spontaneously heal or get a good surgical repair. If it's not treated, then the meniscus can end up being unstable will result in pain and locking, and the meniscal will become what's called a floating meniscus. The meniscocapsular injuries in the medial meniscus, you should look carefully at the peripheral part of the meniscus, which in the sagittal imaging will be posteriorly, and in the coronal imaging will be at the peripheral medial side of the meniscus. Notice that there's a bright signal intensity present here, which is almost the same as water signal, and it is separating the normal fibrofatty tissue, which is present here. In the coronal imaging, the tear is more easy to see. A bucket handle tear, we've seen example of this double PCL sign. And the flipped meniscus we've seen earlier. The displacement of the meniscal tissue can happen below the body of the meniscus, as we can see here, on both lateral and the medial sides. What about post-operative meniscus? We can have, whenever you are asked to comment upon a knee joint in a patient who has had a post-operative repair, then it is very important to try and dig the previous images. Unless you know what the meniscal tissue looked like in the preoperative scan, it is very difficult to see the new findings, how significant they are. People have tried doing MR arthrography, both direct and indirect. Direct arthrography means you inject gadolinium in the knee joint space and then see the little clefts which get outlined by gadolinium, which indicate the presence of a meniscal tear. Or you can use intravenous gadolinium and then image to see if there is any enhancing scar tissue present, granulation tissue in the meniscus. But unless you have the previous imaging, it is quite difficult to know the full significance of these. If you see a clear evidence of fluid bright signal intensity in a meniscus, which connects the meniscal tissue with the articular surface, that's a clear sign of a re-tear. If it was not present in the previous imaging and you see it here, then that's abnormal. A recurrent meniscal tear sometimes can be difficult to see if the signal intensity is not bright enough on fat suppressed sequences, because you cannot differentiate between scar tissue and a meniscal tear. And in these cases, after carefully comparing with the previous imaging, if the question is still there, then we have to revert to some sort of arthrographic examination. Okay, so that's all I had to say about menisci. I'll move on to the cruciate ligaments, which are also extremely important structures, particularly the anterior cruciate ligament. And in physically active patients, I would say 60% of the injuries involve the anterior cruciate ligament. You've got two of them. It's a tale of two structures, remember? The anterior cruciate ligament and the posterior cruciate ligament. The posterior cruciate ligament has got more of a bland, dark, ligamentous appearance to it, whereas anterior cruciate ligament has clearly two bundles, the anteromedial bundle and the posterolateral bundle. The anteromedial bundle looks like the PCL, but it's thinner in size, and the posterolateral bundle has more of fan-shaped appearance, which is present posteriorly. Connects the anterior margin of the tibial eminence with the lateral femoral condyle, and the posterior cruciate ligament connects the posterior margin of the upper tibial eminence with the medial femoral condyle. In the coronal imaging, we can see the lateral side occupied by the ACL in the intercondylar notch, and the medial side occupied by the more globular cylindrical posterior cruciate ligament. In the axial imaging again, we can see the anterior cruciate ligament towards the lateral side, and the posterior cruciate ligament is more towards the medial femoral condylar side. I would encourage you all to look for these ligaments in all three planes. When you have a tear of these structures, in the acute phase, you will end up with a disruption of the ligament, its wavy or lax contour, having increased signal intensity, and replacement of the ligament tissue with a soft tissue mass. So in terms of an anterior cruciate ligament tear, there is a waviness and a lack of visualization of the ACL. We can't see any anterior cruciate ligament, and the posterior cruciate ligament has got a hook-shaped configuration. If you look at the same structure in the coronal plane, we can see the medial side occupied by an intact PCL, but the ACL is gone in the coronal plane. And similarly, in the axial plane, towards the lateral side, there is just some fluid signal intensity with a few floating ligament fibers representing a torn ACL. The femoral attachment of the anterior cruciate ligament is the one which gets torn more commonly. And once it gets torn, you will notice that the ligament fibers tend to sag within the intercondylar notch. Instead of showing a normal taut appearance, it shows a more flappy and horizontal appearance. Again, see them in all three planes, and you will notice that the ligament fiber injury can be identified in all three. Sometimes the radiographers have not aligned the sagittal imaging along the lateral femoral condyle, in which case the contour of the ligament fibers can be tricky, and therefore it's good practice to train yourselves to recognize the cruciate ligaments in both coronal and axial imaging, in addition to the sagittal imaging. Another example of a torn anterior cruciate ligament from the femoral attachment, there is some ligament fibers attached, but they are not normal. They show a abnormal configuration of morphology. And in the coronal imaging, we've got a complete tear. Sometimes, relatively uncommonly, you can get a tear of the anterior cruciate ligament from the tibial attachment site, and that's called a tibial avulsion of the ACL. It used to be a very common injury in the times when children still used to go out to play and would ride a bicycle. I mean, not a virtual bicycle, but a real bicycle. And it was said that if a child falls from a bicycle and ends up with a swelling of the knee joint, they have got tibial avulsion of ACL until proven otherwise. These days, kids, of course, don't go out to do those things anymore. They are all on their computers, and they're getting their joystick thumbs, or Nintendo thumbs, as they're called. But the tibial avulsion of the ACL, you can see a bone fragment, which has avulsed from the tibial attachment site. And in the intercondylar notch, all we see is a big mass of fibrous tissue. It's the partial interstitial tears of ACL which tend to cause a lot of confusion. It was thought at some time, that ACLs don't suffer from partial thickness tears. That clearly is not right, but it's not common. I have seen examples of patients who get a tear of the ACL, and the ligament fibers, instead of showing the normal fan-shaped configuration, it just becomes an amorphous and slightly edematous mass of ligament fibers. And if you look carefully, you will see associated signs like knee joint effusion. History is very typical. They have had some injury and they have got pain. So you can have a sprain of the ligament, and then with time it will settle and the sprained ligament will end up showing some signs of some type of scarring. When you get a tear of the ACL, you will end up with some secondary signs. The lateral condyle of tibia can travel more anteriorly. I think it's more than 5 millimeters. It's about 7 to 10 millimeters at least, if you compare it from the back end of the lateral femoral condyle. The posterior 1/3 of lateral meniscus gets uncovered because of the anterior position of the tibia. The posterior cruciate ligament will get buckled. You will get a characteristic bone bruising present on the lateral femoral condyle and the medial femoral and tibial condyles. You will end up with injury to the medial collateral ligament and a deep lateral femoral notch. All these are indirect secondary signs of ACL, but in patients in whom the clear evidence of a direct full thickness tear is not present, it's very useful to have a knowledge of these secondary signs. So this is what I meant by saying that there is an anterior tibial draw. That's the lateral side of the tibiofemoral joint. That's the lateral tibial condyle. And if you draw a straight line from the back end of the lateral tibial condyle and measure the distance of the line drawn from the back end of the lateral femoral condyle, if it's more than 7 millimeters, that is significant. You will have the uncovering of the lateral third of the posterior horn of lateral meniscus, which is posterior to the upper tibia. You will have a hook-shaped configuration of the posterior cruciate ligament. If you draw a line from the back end of the PCL and take it up, it just goes parallel to the posterior margin of the femur. Normally, this line goes like that. But in terms of ACL tears, the PCL posterior line goes parallel to the back end of the lower femur. The pivot shift injury happens when the knee joint is rotated with a valgus force. And when that happens, you end up with damage to the medial collateral ligament, which is completely gone. This is a right-sided knee. The force was coming from this side, and that results in the upper femur getting bent this way and lower tibia getting bent this way, which puts a greater degree of tensile force on the MCL, and it gets torn. With a tear of the anterior cruciate ligament. You get characteristic bone bruising, which is present on the lateral femoral and tibial condyles. And you get some edema of the medial femoral condyle also. Another example of the full thickness rupture of ACL. Notice the bright signal intensity present and bone bruising on the lateral side of the tibiofemoral articulation. When the ACL tear is torn, you will get tears of the medial meniscus. You will end up with meniscocapsular contusions and tears of the posterior horn. You will get lateral compartment contusions and medial tibial contusions. Not everything related to the anterior cruciate ligament is because of ACL tears. You will have situations in which there would be bright signal intensity within the anterior cruciate ligament, and this is in keeping with an anterior cruciate ligament ganglion cyst. And when you get these ganglion cysts, these are actually myxoid degeneration of the anterior cruciate ligament connective tissue fibers, and you end up with this bright signal intensity, which tends to splay the ligament fibers. With the mucoid degeneration of anterior cruciate ligament, the ligament fibers become swollen, and this is called the drumstick appearance or the celery stick appearance, and that's a it's not a tear, it's a mucoid degeneration of the ACL fibers. Normal alignment of the anterior cruciate ligament should be parallel to the Blumensaatz line. This is a line which is the line drawn along the roof of the intercondylar notch. So normal satisfactory placement of anterior cruciate ligament reconstructive fibers should be parallel to this line. When the ligament fibers are more vertical like that, so that's the Blumensaatz line, and you can see that the reconstructed ACL fibers are more vertical, then that means that the ligament is not going to be able to do its normal job of keeping the tibia in position when coming down. It will carry on going back. So that's an incompetent ligament. It's a badly positioned tibial tunnel. It's very important to try and assess these when you're looking for effective repair of the anterior cruciate ligament. And you will come across these patients very commonly. It's a very common repair procedure done. And we as radiologists are asked to comment upon the adequacy of the repair. And what we need to do is to find the central sagittal image, find the Blumensaatz line, and then see the relationship of the tibial tunnel as compared to the Blumensaatz line. In terms of complications of anterior cruciate ligament, the tibial tunnel can be too far back or too far anterior. If it's too far anterior, it will result in the impingement of the ligament fibers caused by its rubbing against the roof. And if it's too far back, then it will be incompetent because the tibia will continue to come forwards. So normally it should be parallel like that. And if it's too far to the front, then the ligament fibers will rub against the intercondylar notch and the ligament fibers will disrupt and it will become an incompetent repair again. When you see that sort of appearance, then all the secondary signs of ACL incompetence will become visible again. So you will have the anterior tibial draw, and you'll have the hook-shaped PCL. We will have disruption of the ligament fibers with lack of visibility of the reconstructed ligament fibers into intercondylar notch, both on sagittal and on coronal imaging. And you will end up with fibrosis present in the anterior aspect of the intercondylar notch, which is called the Cyclops lesion. So there's normally, you will see at least some fibrosis. It's very common to see that anterior to the ligament fibers, but once this becomes hypertrophied, then that becomes symptomatic and the patients will have a problem in terms of pain in the front of the knee joint. PCL injuries, by comparison, are relatively less common and less important. But once you see them, it happens because of injury to the front of the tibia. So like a dashboard injury, this force pushes the tibia back and that results in disruption of the PCL. When you see it, it's one of the most easy structures to recognize in knee joint MR because it's very thick and very bland. And when you see it getting disrupted, you will see that quite easily. It can result in a globular swelling of the ligament fibers. You can get mucoid degeneration with big meniscal, ligamentous ganglion cysts within it. And you can get disruption of the ligament fibers from the femoral attachment and in the mid substance. The femoral attachment of PCL happens less commonly, but it does happen. And when you have that, it's got a big bone fragment which has disrupted from its femoral tibial attachment site. And thankfully, this has got a better prognosis because bone tends to heal better than the ligament itself. So the same patient, when you see example on MR, we can see fluid signal intensity separating the tibial attachment of PCL with some surrounding bone marrow edema. Moving on to the collateral ligaments, we've got the medial and the lateral collateral ligaments. The Medial collateral ligament is present more anteriorly. The lateral collateral ligament anteriorly, lateral collateral ligament complex, I should say, anteriorly has an iliotibial band. And then further posteriorly, it has the lateral collateral ligament proper and the biceps femoris tendon, which forms the conjoint tendon and attaches to the upper fibula. So the MCL is more to the anterior side and the lateral collateral ligaments are present more posteriorly. When you've got a grade 1 sprain, then you will have edema present at the superficial aspect of the MCL. When you have got a grade 2 sprain, you will have some disruption of the ligament fibers and edema present on both superficial and deep aspects. That's the coronal image of the right knee joint, fat suppressed sequence and non-fat suppressed sequence. We can see disruption of the fibers of MCL. There's a medial meniscal tear also present. And a grade 3 tear is when you've got a full thickness tear. This is the left knee joint. We can see there's a full thickness disruption of the femoral attachment of the medial collateral ligament, lots of bone bruising and soft tissue edema. You can have multiple ligaments getting injured. Of course, you will have this patient showing examples of injury to the MCL, to the iliotibial band, and to the lateral collateral ligament. So significant knee joint trauma. The joints, patellofemoral and tibiofemoral. The commonest disease that affects mankind, and by disease we mean something which affects the quality of life, is damage to our cartilage. As we grow old, we tend to lose it. We will end up with a condition called chondromalacia. And when patients present with knee joint pain, yes, they have ligament tears and yes, they have meniscal tears. That's what we've discussed. But what almost everybody will have after a certain age group is damage to their cartilage lining. And therefore, it's very important to understand that A, this is a very common finding, and B, when you're describing it, how should you be wording your report so that the treating clinician is helped in their management plan for the patient. It's also one of those findings which gets vastly underreported. MR is not particularly good at picking up the earlier stages of chondromalacia. And when the reporting radiologist has not trained themselves properly to look at the cartilage loss, they will underreport that also. So you get stages of problem. You have initially chondromalacia, which means the cartilage is soft, then it becomes torn, it becomes eroded, which leads to subchondral bone getting edema and bruising, which then increases to form subchondral geodes or little cysts under the cartilage surface in the bone. And then finally, you end up with malalignment problems, which means that by that stage, it's too late for any effective conservative treatment. Patellofemoral joint is a part of the extensor mechanism of the knee. There are some anatomical variants of the patella in terms of bipartite patella, which means that there is an accessory looking ossicle present at the supralateral margin of the patella. The position of the patella can vary in terms of a high position or a low position. And there are differences in the morphology of trochlea, which can be shallow or dysplastic. Then we've got problems with the quadriceps tendon and the patellar tendons and fat pads. Thankfully, the bipartite patella, though it's relatively common, is not difficult to differentiate because it almost always happens at the supralateral margin of the patella. It is usually asymptomatic, but in some patients, you can have a symptomatic bipartite patella. And in those patients, it can be a little bit displaced and there can be some edema on the fat suppressed sequences in the ossicle. This is an example of a patient who can have a symptomatic bipartite patella, which will have, this is a coronal imaging, this is a lateral side, this is a right knee joint, and we can see that there is edema present, not just in the bone, but also in the adjacent surrounding soft tissues. Another example, and notice here that the bone fragment is a little bit displaced, and there is some fluid cleft separating the main patella from the bipartite patella. This patient also has some joint effusion. Another example of edema present at the margins of the synchondrosis between the bipartite segment and the main patellar segment here. There is another example called the dorsal defect of patella. So in this case, there is a deep surface cleft in the bone, which is covered by cartilage. This also tends to happen in the superolateral side of the patella. The overlying cartilage is usually intact, and that's what tells the difference between a normal variant versus a pathology in terms of a possible chondral defect. The patellofemoral joint, which predisposes to patellofemoral dysfunction or pain, is the one in which patella is maltracking. So when the patients move, their patella tends to go laterally. The medial side of the knee joint structures are trying to check the patella position and try to keep it more central, but it tends to keep on moving laterally. And when it does that, then it will end up with the fat pad getting impinged between the lateral patellar facet and the lateral femoral condyle. It tends to happen more commonly in patients who have a high riding patella because there's more moment of movement and it will cause more movement laterally. And in patients in whom the trochlea is very dysplastic. That is, they have got a very shallow looking trochlea, which is not able to keep the patella in check. You tend to assess the degree of height of the patella by calculating the Insal-Salvati ratio. And it's very easy to calculate that. It was initially described as the length of the patella and length of the ligamentum patelli as measured on a lateral plane X-ray. And as you know, a lateral plane X-ray is taken with a slightly flexed position of the knee. Most knee joint MRI scans are performed when the knee joint is fully extended. It should be performed with a slightly flexed position, but the reading still correlates well with the Insal-Salvati ratio. And therefore, on MR, we can do a modified measurement. Find the longest length of the patella in the sagittal imaging, find out the length, find out the length. This is the numerator, this is the denominator. You get a ratio of tibial length and the patellar ligament length. And in females, if it's more than 1.5, it's abnormal. In males, if it's more than 1.32, it's abnormal. I tend to use a 1.4 figure, easy to remember, works in both roughly. You get an idea. When the patella is low-lying, that's patella baja. In females, it's less than 0.8. And in the males, it's less than 0.74. Again, I just use the same one measurement, 0.8. It's easy to remember. So patella baja is usually seen in patients who have got fibrosing pathology of the ligamentum patelli that tends to pull the patella down. And patella alta, the high riding patella, is generally seen in younger patients who have got problems with lateral maltracking pathology, which I've mentioned. Remember, when you're doing this, the structure which is the lower one goes on top of the ratio, and structure which is the upper one goes on the bottom of the ratio. Easy to remember. The trochlear dysplasia is the example of a dysplastic, shallow looking trochlea. So if you look at the axial imaging here, notice that normally the trochlea has a medial facet and a lateral facet, and the lateral facet is larger normally. In this patient, we can see that A, the trochlear facet is almost equal between lateral and medial sides, and B, it's not a V shape, but a rather flat line. So this dysplastic trochlea is not going to be able to keep the patella in its position, and the patella will keep on wanting to go further laterally when the patient moves. Another very useful observation which indicates the presence of a dysplastic trochlea is in the sagittal imaging. Normally, you get a very little femoral condyle going in front of the line which you draw from the anterior margin of the femoral cortex down. When you get this sort of a step-like deformity here, that's a very good indication of a dysplastic trochlea. Some people get confused with this axial imaging morphology because if you look at the very cranial slices in the axial knee joint, a vast number of patients will have trochlea looking like that. And as you come down, it becomes to show more of a lateral and medial division. But the way to tell the difference between a normal and an abnormal is to look for the sagittal imaging. And if you get a shallow looking trochlea which has this step-like deformity, we are more confident that we are dealing with a shallow dysplastic trochlea. So ventral trochlear prominence of more than 7 millimeters, this thing, a step-like transition zone, and a shallow trochlear groove, which is less than 3 millimeters in depth is, so you join a line from here to here, and if the depth is less than 3 millimeters, that's a dysplastic trochlea. People have defined all sorts of criteria and measurements, and you just get confused. I'll show you some of the eyeballing features which you can use, which will help you decide if you're dealing with a dysplastic trochlea or not. We've already discussed the step-like deformity, which you can just eyeball. The second one is that you just look at the disposition of the patella, and if it is tilting more posteriorly, then that's a dysplastic trochlea. The patella begins to go laterally by more than 6 millimeters from the lateral femoral condyle. That's a dysplastic looking trochlea. You can calculate the trochlear tibial tuberosity distance. So you find where the deepest point of trochlea is, higher up in the knee joint. You put your mouse on that, and then you scroll down till the time you reach the tibial tuberosity, and then you just calculate the distance between that point and that point. If it's more than 2 centimeters, that's a lateralized patella and a dysplastic trochlea. There is one other finding, which is on this one here, that you get a lateral trochlear inclination. So the trochlea, when it comes to its disposition, it just becomes too shallow. In fact, a little bit convex on this side, which is the example of a dysplastic trochlea. So these 2 or 3 criteria, if you begin to use in everybody, you will get a very good eye developing, which will help you assess about the dysplastic trochlea. Shallow, step deformity, and lateralization of patella on a background of a patient who has a high riding patella. These are quite useful findings. And then the trochlear tibial tuberosity distance is also quite an easy one to remember and practically use. When you're assessing for ligamentum patelli, remember that this structure, particularly close to its attachment to the lower pole of patella, is subject to magic angle artifact. This you will see in short TE sequences, the proton densities and the gradient echo, if you're still using it. Do not confuse that with tendinopathy. The patellofemoral joint pathology is relatively common because you will end up with chondromalacia and osteochondral defects. You will get these patients having osteoarthritis and sometimes an acute setting of trauma. Excessive lateral pressure syndrome will result in edema of the lateral aspect of the Hoffa's fat pad. Chondromalacia patelli, as I explained earlier to you, is one of those findings which frequently gets underreported. Initially, you will have the ligament which is got some bright signal intensity. That's chondromalacia, softening of the cartilage. That gets underreported. Then you will have a partial thickness cartilage loss. So there's a fissure defect, but there's some cartilage still present. And then you'll have a full thickness cartilage loss with subchondral bone marrow edema and small cysts formation. So grade 1 is just edema. Grade 2 is the defect, which is less than 50%. Grade 3 is defect, which is more than 50%. And grade 4 is full thickness defect with subchondral change. These are the 4 stages of chondromalacia. The fractures of patella, you can have the acute fractures and you can have the stress injuries of patella. The difference, of course, is in the history. You can get a patellar sleeve avulsion fracture, which is the ligamentum patelli pulling on the lower aspect of the patella, which ends to end up with a small fragment of bone and soft tissue edema. And osteochondral defects, which can happen in children and are not that common. Chondromalacia, if it can happen on the patellar side, can also happen on the trochlear side, and that again is something which is commonly underreported. If you look carefully, and it follows the same classification of grade 2, 3, 4 that we discussed in chondromalacia of the patella. One peculiar pathology which you see in patients with acute injury to the extensor mechanism is the lateral patellar dislocation. It results in an impaction injury which happens on the lateral femoral condyle and the medial patellar facet. So this patient is an example of a left knee joint. That's the medial side, that's the lateral side. Excessive lateral pressure results in disruption of the medial stabilizing structures of the patella, injury to the medial patellar retinaculum. The patella goes laterally, it hits the lateral femoral condyle, you end up with bone bruising on these 2 sides. Then the patella tends to relocate and we end up with just the telltale signs. So this is how it happens. Left knee joint, lateral side, medial side, big lateral facet. Lateral side force comes into play, takes the patella laterally. You end up with kissing bone contusions. You end up with injury and the patella then comes further laterally. You get injury on this side. You get injury to the medial patellar retinaculum, and then the patella tends to go back. So you end up with bone bruising here, injury on the medial side. And because the patella is relocated, we have difficulty explaining this bone contusion pattern. This is an example of such a case. Notice here that this is the right knee joint. So this is the lateral side, this is the medial side. The patella has relocated now, but we've got bone bruising on the lateral femoral condyle. We've got injury to the medial patellar retinaculum, and we've got some bone bruising on the medial patellar facet. So that's the mechanism how it's happened. This patient also had injury to the medial collateral ligament, which has got a full thickness rupture. Another example, this one is the left knee joint. Notice again bone bruising on the lateral femoral condyle and bone bruising of the medial patellar facet. Right knee joint, same thing happening here, and injury of the medial restraining structures of the patella. Excessive lateral pressure syndrome. This was the other finding which I was looking for earlier. When the patella is more laterally tilted, it will have more chances of getting chondromalacia. And that's another example of abnormal lateral tilt of the patella, which tends to result in chondromalacia. Pathology of the patellar tendon is relatively common and tends to happen in both acute and in chronic settings. We can also have infiltrative disorders in terms of gout, tophaceous gout, and joint cell tumor of the tendon sheath, affecting the ligamentum patelli. In terms of acute trauma, we can have disruption of the ligament fibers from the patellar attachment very commonly, in the mid-substance relatively less commonly, and tibial tuberosity avulsion with a bone fragment present on the deep surface. Tendinopathy or overuse, I've seen that very commonly in patients with like football players, and they get thickening of the ligamentum patelli. Notice that this thickening is much more than the magic angle artifact that I explained earlier. We've also got bone bruising and deep surface partial thickness tear. And these ligament injuries can respond favorably to injections of platelet-rich plasma. The tendinopathy can be quite diffuse, limiting to distal half or the whole length of the ligamentum patelli, and you can end up with delamination tears. There are 3 different examples, and you've got proximal, distal, and diffuse entire length of ligamentum patelli, showing the effects of trauma and tendinopathy. In terms of chronic cases, the syndrome is called Sinding-Larsen-Johansson's disease. That's the chronic avulsion injury of the proximal tendon bone junction. If you do plain x-rays, you will see a small bone fragment and swelling of the tendon with a small bone fragment present at the lower pole of patella. When it comes to distal attachment of the tendon, you've got the Osgood-Schlatter's disease, which is a chronic avulsion syndrome of the distal attachment of the ligamentum patelli. Just the bone fragmentation is not enough to make the diagnosis. You've got to have the bone bruising and the surrounding soft tissue edema, which will confirm the diagnosis of Osgood-Schlatter's disease. The patients who have got a high riding patella and have a tendency of lateral patellar subluxation can end up with bone soft tissue edema affecting the lateral Hoffa's fat pad. And these patients have the chronic impingement of the fat pad secondary to patellar maltracking. And we can see this on both sagittal and on axial imaging. This is a more obvious example of Hoffa's fat pad impingement. Sagittal imaging, lateral side shows edema of the fat pad. Axial imaging shows that the lateral side of fat pad has got a significant degree of edema, and the same finding in the coronal imaging. So a wide variety of pathologies affect the extensor mechanism. Remember that there can be patellar tumors like chondroblastomas and giant cell tumors. We can have infections in terms of osteomyelitis and TB, and inflammatory arthropathy and enthesopathies. Extension mechanism injuries, extensor mechanism injuries tend to occur in extended and in locked knees. There can be a marked impaction anteriorly with marrow edema of the contiguous surfaces. The soft tissue injuries on opposite sides, and posteromedial and posterolateral corner injuries. The flexion injuries are less extensive bone bruising. We've got ligamentous disruption, shearing and rotation injuries, non-contiguous bone marrow edema, and tap and twisted mechanisms. Dislocation of the knee is relatively less common, but we still see it. There are strong ligaments, but there are stronger forces around. So we have seen examples of very severe ligamentous and capsular damage with popliteal artery injury happening in almost a fourth to half of the patients. Anterior dislocation is most common, which happens to happen in hyperextension mechanism of injury, with tearing of the posterior capsule and of the PCL. So here is an example. You can see that the lateral X-ray shows that the tibia is significantly anterior and the femur is at the back. In the coronal imaging, there is a coronal plane malalignment with avulsion bone fragments, very severe trauma. And of course, in these patients, you worry about possibility of injury to the popliteal artery, which is at risk here. In knee joint dislocation, you will have bizarre patterns of bone bruising and soft tissue injury affecting both lateral and medial sides. Very extensive injury to the posterior aspect of the knee joint soft tissues. Imagine what is happening to all the neurovascular bundle present here, with disruption of the ligaments, bone bruising, and significant soft tissue trauma. This injury, although I've said that it's not common, but it does happen. And I've seen examples of it not uncommonly, showing multiple ligamentous traumas and surrounding soft tissue injuries. So what I've done in this quite exhaustive roundup of knee MR is that we have seen the tale of two structures, the two menisci, the two cruciates, the two collaterals, and the two joints. You've got to have a systematic approach so that you do not miss anything. And the more cases that you see, the more strength you will get in your diagnosis. I'm going to stop here, and the next phase is that I've got about half an hour in which I'm going to show you some cases. These are live cases, and I'll just show you how I report them and what pathology, some of the pathologies we've seen. I'm going to share them in the case format with you. So just bear with me. Let me stop sharing, and I'll bring up the cases. Joint on presented with history of you can see a case on the screen, and he presented with history of pain in the knee joint. And when I see the knee joint on such patients, I would start off by an assessment of the sagittal imaging first. So this is the left knee joint. And we can see that on the lateral side, we first start off by looking at the conjoint tendon. We've got the lateral collateral ligament, and we've got the biceps femoris tendon attaching to the upper fibula. Then the lateral meniscus is seen. We've got the superior tibiofibular joint. Notice that the lateral meniscus has normal anterior and posterior horns. We go towards the central and more medial side of the knee joint. Then we've got the anterior cruciate ligament, and we've got the posterior cruciate ligament, right start. starting there. We've got the start of the medial meniscus side, and this is the peripheral part. Bright signal intensity present in the contiguous with the inferior meniscal surface on at least 2 slices. So that's the 2 slice touch rule, which has been fulfilled here. So we know that that's a 96% accuracy in terms of confidence of diagnosing a meniscal tear. And then as we come further towards the intercondylar notch, the bright signal intensity continues to involve the posterior root attachment of the medial meniscus. So we go to the coronal imaging now, and notice that's a lateral side, that's a medial side. The bright signal intensity is continuous in the attachment site of the posterior root. And this one image is the most important image in any knee joint assessment, because that allows you to assess the posterior root of medial meniscus, which has a tear in it. Plus the degenerative horizontal cleavage tear is communicating with the inferior meniscal surface in both the coronal and in sagittal imaging. So extensive tear of the medial meniscus. Then while you are on the coronal imaging, notice that the medial collateral ligament is markedly swollen. There is some low signal intensity here, but there is extensive edema present at the superficial and deep aspects. There is fluid signal present deep to the medial meniscus, medial collateral ligament between the MCL and the medial femoral condyle. The distal attachment of the MCL goes a long way down, almost 10 centimeters down the joint line, and quite a few radiographers do not cover that entirely. So make sure that this is adequately covered in all of your scans. We're happy that there is no tear of the lateral meniscus. We've got a contusion of the medial collateral ligament, femoral attachment. We've got a medial meniscal tear. Then the anterior cruciate ligament is nicely seen in the coronal imaging. The PCL on the medial side is seen in the coronal imaging. Iliotibial band anteriorly is okay. Posteriorly, the lateral collateral ligament is fine. We've got the popliteus tendon here with the popliteo-fibular ligament at the posterolateral aspect of the knee. Then we look at the axial imaging. Extensive soft tissue edema on the medial side. So there has been injury to the medial patellar retinaculum. The patella does have a lateral subluxation. There is a little bit of knee joint effusion. As we come down on the medial side, we've got edema around the femoral attachment of the MCL. That was the sprain of the MCL ligament. We've got the tear of the posterior root attachment of the medial meniscus. And in the axial imaging, we also see that there is cartilage irregularity present on the lateral patellar facet, chondromalacia. And the trochlea is dysplastic, a little bit. Shallow. When we see the sagittal imaging, can you see the step-like deformity at the anterior aspect, which is what I explained earlier? If you see that on the non-fat suppressed sequences, you will appreciate it better. You can see that little step here. So multiple pathologies. This patient has posterior horn and body of medial meniscal tear, a medial collateral ligament injury, possible little bone fragment. So careful assessment of plain x-rays to see if there's a bone fragment present here. Soft tissue edema and at the anteromedial aspect of the knee, which was seen here. a dysplastic trochlea, and in the sagittal imaging, there is a little well-formed ossicle present at the deep aspect of ligamentum patelli, but on the sagittal PD fat-sat sequence, there was no edema within this bone fragment, so it was chronic and of questionable significance. So that's one case, and that's how I would analyze them, working from one side and going to the other. I'm going to show you another case now. So this is a 27 years old male, and he was complaining of bilateral knee pain for the last 5 weeks. He is a keen tennis player. So I'm just going to show you, for the benefit of showing you more, the chance of showing you more cases, just two sequences, coronal and axial. If you look at the axial imaging, we can see that the trochlea here is quite well formed. So there's no dysplasia as we saw in the previous patient. No chondromalacia is seen. The cartilage is quite thick and of uniform signal intensity. As we come down, can you notice this oblique shaped meniscal tissue, which goes like that? So that's the lateral side. That's the posterior horn of lateral meniscus. And there is a ligament connecting that with the anterior horn of medial meniscus. Follow that on the coronal imaging. That's the lateral side. That's the medial side. So anterior horn of medial meniscus. Posterior horn of lateral meniscus. So follow that. See that little structure, that little structure, that little structure, and that connects with the anterior horn of medial meniscus. This is a normal variant, and this is called the oblique menisco-meniscal ligament, that thing there. It's very rare, but when you see that, you can easily confuse that as a bucket handle fragment. The way you can tell the difference between this as being a normal variant versus a bucket handle fragment is, with a bucket handle fragment, you have to have an attenuation of the meniscus. There's no attenuation here. The meniscus is well formed. If you look at the sagittal imaging, we can see bow tie, and we can see normal meniscal morphology, and we can see no attenuation or missing meniscal fragments. So that thing which we saw in the intercondylar notch, it's just getting lost here. It's probably just around there. Is a normal oblique menisco-meniscal ligament. I thought it'll be a nice one for you guys to see as a normal variant. Next case is if you look here, this is right knee joint. So starting from the front, medial side, notice this image. I told you that you must always very carefully see the posterior root of medial meniscus attachment to the posterior aspect of central tibial eminence. And in this case, there's a little cleft here. Professor Resnick says that this one image is the most important image in knee MR, the one which allows you to see an intact attachment of the posterior root of medial meniscus. And if you can't see that, we'll notice that and then try and see what it looks like on a sagittal imaging. You see here? It's going to mag it up. There is some knee joint effusion and a loose body. That's the PCL. As you scroll from the PCL towards the medial side, you should be able to see the posterior root of medial meniscus in everybody. But here, it has got bright signal intensity within it. And we see that there is a tear. So that's a tear of the posterior root of medial meniscus. Let's see if we can find the same thing on the axial imaging. And that's it there. In the axial imaging, we can see that we're exactly triangulating that on this. And normally there should be a meniscal tissue here. We've got bright signal intensity, plus there's fluid at the back as well. There is some ganglion cyst formation at the back. So there's a tear of the posterior root of the medial meniscus. That's very important finding. So please see that carefully in all of your patients. Once you've got the posterior root of the medial meniscus torn, then the body of medial meniscus will get extruded more medially. And you'll have multiple other findings. Like in this case, you've got these two loose bodies in the knee joint. There is thickening of and scarring of the medial half, proximal half of the medial collateral ligament. So the more you begin to see, the more pathologies you will pick up. But I wanted you all to see this very important finding in this patient. So please try and see that in everybody. Okay, so this patient is a 40 years old male patient. He has got history of 1 year history of knee joint pain. And he says that the knee can go out. These are the patient's own words. So we're going to see what the examination shows. We'll start with the sagittal. This was a left knee joint. So we're starting from the medial side. We've got the pes and serinus tendons on the medial side. So there's a little bit of fluid present along the tendons. There is bright signal intensity in the posterior horn of medial meniscus. And we can see it's an oblique and irregular shaped configuration of a tear, which communicates with at least 2 slices, contiguous slices, 3, 4 slices. So there's a complex shaped tear of the posterior horn of medial meniscus. As we come towards the posterior root, notice that this posterior root is normal. We've got the PCL, and on the same slice or on the very next slice, we've got an intact posterior root. Compare that with the patient I just showed you earlier in the coronal imaging, and you can see that the posterior root is intact here. little bit bright, but you've got a much more meniscal tissue getting attached as compared to what you saw in the previous patient. And again, we can see the same tear going all the way. You've got a bit of a longitudinal configuration dividing the meniscal tissue between lateral and medial sides. And then you've got a bit of a more horizontal oblique configuration dividing the meniscus into upper and a lower half. So you've got a bit of both. You've got a bit of a longitudinal tear and a bit of a horizontal cleavage type tear in this 40 years old male patient. Going back to the sagittal to confirm what we saw, on the medial side, we've got normal ACL, we've got normal PCL. The line drawn here touches the femur, doesn't go up and up like that we saw in the earlier case. Then we've got an intact and normal looking lateral meniscus, a normal conjoined tendon and collateral ligament. As you come towards the central part, notice there's a little ganglion cyst here. And what I showed you earlier, that the anterior horn of lateral meniscus can be a bit feathery, like you see here. That's normal, because it's got fibers of ACL interdigitating with it. So don't call that as a tear. Yes, there is a little ganglion cyst, but there's no tear. Also notice that there is a bone fragment present deep to the ligamentum patelli. There is a bit of a bone marrow edema in this bone fragment, so that can be a cause of patient symptoms of anterior knee pain. Ligamentum patelli, close to the attachment to the patella, shows some swelling and edema. So there is some ligamentum patelli tendinosis. There is some soft tissue edema present at the superficial aspect of lower ligamentum patelli. Have a look at the axial imaging. We've got the bright signal intensity in the lower ligamentum patelli. In the axial imaging, we've got some bright signal intensity in the upper half. No chondromalacia patelli. So this patient has a complex shaped medial meniscal tear, some longitudinal component, some horizontal cleavage component, a well-formed bone fragment deep to the ligamentum patelli, and some ligamentum patelli tendinosis. Okay, I think I've got time for at least one more case. So this patient is a 35 years old male patient, complains of general discomfort for the last 1 to 2 years. Now the symptoms are getting worse. So these are real life cases, and these are the histories which were provided to me when I reported them. So right knee joint, remember 35 years old and 1 to 2 years history. We can see that there is a big osteochondral injury present on the medial weight-bearing surface of the medial femoral condyle here. The bone fragment, when you see that, that's the classical location of osteochondral injury of the femoral condyle, present on the medial femoral condyle, weight-bearing surface. The good signs here are that the overlying cartilage appears to be intact. Number two, the deep cleft that we have is bright signal, but it's not very wide. And there is no subchondral bone marrow edema present. If you look at the non-fat suppressed sequences, notice that this lesion of loose body of the cartilage has got a very low signal intensity. So which means that it has not got the normal fatty marrow and this marrow is necrosed. Because he's quite old, he must have developed this when he was younger, and he's been carrying on with it. Therefore, the osteochondral injury has become showing signs of necrosis, but at least it is stable. By stable, I mean that when he moves around, this is not flopping around in the knee joint. It's still holding in its place, but this is not normal, and he would need some sort of a surgical repair. We would do all the other things that we've discussed earlier. So we start from the lateral side. We've got the conjoint tendon. We've got the lateral meniscus. We've got a little bit of bone bruising at the back of the lateral tibial condyle. We've got chondromalacia of the lateral femoral condyle. The cartilage normally should be like this, but notice here it becomes irregular. So there is at least a grade 2, maybe grade 3 chondromalacia. So I would measure it for my report. So I would say that front to back, this is 3.3 centimeters in size. Again, notice the feathery look of the anterior horn of lateral meniscus. We've got the normal cruciate ligaments. We've got the posterior root of the medial meniscus here. We've got a little ganglion cyst present at the back of the posterior horn of the medial meniscus. We've got the osteochondral defect we saw earlier. There's no medial meniscal tear. Another thing to note is that he's got the step-like deformity. So we will have a look at the axial imaging to look for the dysplastic trochlea. We've got knee joint effusion. Quadriceps tendon and ligamentum patelli look okay. So have a look at the axial imaging now to see if the trochlea looks dysplastic to us. Knee joint effusion, it's reasonably well formed, so I would not be too fussed about that. Patella is also not laterally subluxed, it's holding its position. And the angle between the medial and lateral corners of the patella is not too far tilting. If you want to measure the trochlear tibial tuberosity distance, you find the central point of trochlea, then you go down to the tibial tuberosity. I've not moved the mouse, so come down, and from there to the central tibial tuberosity, it's only about 1 centimeter here. So we are allowed up to 2 centimeters. So the trochlear tibial tuberosity distance is normal. So in summary, we've got that big osteochondral injury present on the weight-bearing surface of the medial femoral condyle, which looks stable but has necrosis. Then we've got the knee joint effusion and synovitis, and we have got ganglion cyst present behind the medial meniscus posterior horn, and we've got chondromalacia of the lateral femoral condyle, which we saw just on that side. Okay, Sir Sami, am I okay to carry on, or you want Dr. Barber to take over the Viva bit?
Yes, I think thank you very much. I think that was brilliant. So Babar will take 2 candidates. So I think we'll go with Babar
now. The things I would normally look at and the way I would have reported it. And then we'll just do a sort of a small Viva session with candidate 1. The candidate 1 already has the control. So what I'm going to do is just give you a little bit of history. So this patient is a young patient, 24 years of age, and presents with a twisting injury whilst playing football. So this is the MR scan of the knee that we've been given, and here you go.
Okay. So this is a sagittal PD fat set sequence of the right knee. Sorry, I'm just trying to scroll through. It's a bit slow. Okay. So I can see there are bony contusions demonstrated on the anterior femoral condyle and posterior tibial plateau, and that's on the medial side. Let me show the images. Okay, so I can see the PCL, which is intact. I'm just going to look at the ACL as well. Okay, so there is the ACL appears swollen and enlarged. There is bony contusions along the tibial insertion point of the ACL. So at the moment, I'm concerned about a ACL sprain. I'm just gonna review the rest of the images. Okay. Right, so going back to the ACL, so there's discontinuity of the ACL fibers, particularly at the femoral insertion point, attachment point. So I'm at the moment worried about a ACL tear. There is a small volume of knee joint effusion as well. The PCL is intact. I'm just going to have a look at the coronal view as well. Yep, so there are bony contusions on both sides, the medial and lateral aspect of the femoral condyle. And there is some soft tissue swelling over the lateral knee joint. The menisci appear intact. I'm just looking for any obvious osteochondral defects, which I don't see. So in essence, so there is bony contusions on the medial and lateral aspects of the femoral condyle, and also posteriorly on the tibial plateau. There's discontinuity of the ACL fibers, particularly at the femoral attachment point. Therefore, appearances are consistent with a ACL tear. And yeah, I'll be contacting the orthopedic team to make them aware of the patient.
Okay, good. The only thing I would say that I want slightly more confirmation is your ACL tear. Do you think it's a partial thickness tear? Do you think it's a full thickness tear? Or is it a sprain, as you said initially?
I think it's a full thickness tear because I can't see the fibers on the posterior aspect clearly. So I think it's a full thickness tear. Okay, and of the femoral attachment, as you said? Yeah. Okay, so we'll take the control back. I think I can take the control back, stop remote control, so it'll be easier for me to scroll through. Right, so that's a good attempt, but of course it's only less than half the attempt you would expect in an exam situation. So there are lots of findings that you need to pick up. And of course, in an exam situation, we completely understand there'll be lots of pressure on you. And because of that pressure, there's an urgency to quickly run through the images. Now, remember, in most of the exam situation, there'll be multiple findings, and you have to correlate in your mind everything together. That's what we always tell our registrars, how you're going to correlate everything together. So I will go through the case with you, and I'll sort of in between also tell you how I would have looked at it, because remember, it's also an art to present because in an exam situation, you've got to know the findings, pick them up in a very short span of time, and then present it to the examiner. So that's what we're going to do. So I normally start by dividing, in this particular case, into 2 screens. Of course, when we're doing it on our PACS monitor, we have about 8 different screens demonstrating all the images. But let's assume if I had the option, what would I show first, or what would I look at first? I would always start with the sagittal PD sequence, because that's the most important sequence, which will show you almost all the pathologies. Of course, it will reduce the intensity of the bone marrow edema that you'll see in the bones, but then you've got T2, you've got T1 sequences to look at. So we will, of course, look at all of these sequences. But if I was to start with one particular sequence, I would normally start with the sagittal, and I'll normally start from lateral to medial, so I can look at the structures I always look at. And on the other side, I'd normally bring up the coronal as we've given you, so you can actually cross-reference things, because if you're not sure about one thing, you can always go to the same area on the coronal scan to see if what you were looking at on the sagittal is actually a true finding. So let's look at the sagittal PD sequence on this side. And the first sequence, the first initial sequence from the lateral side, you'll see this dark structure. It'll be a sort of what we call a Bugs Bunny appearance. In other words, you see 2 black ears. So that's the biceps femoris, and this is the lateral to lateral ligament, and you can see the fibular head. So this is a really important sequence, because if there's lots of damage to this on the first sequence, if there's lots of edema, you start thinking about ACL immediately. So that's the first thing I would go for. And as I move centrally, I immediately look at the femoral condyle and the posterolateral tibia. And at this point, this is the most important finding. Even without doing anything, I can tell you now that this patient has got a complete ACL tear. Why? Because of the contusion pattern. Look at the bone marrow edema of the lateral femoral condyle and the posterolateral tibial corner, perhaps subtle marrow edema of the fibular head. So you can straight away tell that there's damage to the ACL. What extent? We'll come to in a second. At this point, I also cast a quick eye on the lateral meniscus. Now, as Dr. Butt was telling you, you can see a nice triangle of the lateral meniscus there, except for a little cleft here, which I'm not sure about at this stage, but remember, we've got a coronal sequence at the same time on the other side of the screen that we are looking at. So let's just have a quick look at the coronal to see if there's anything there. And can you see immediately there is a vertical cleft here that you can see. Now, this should have been a nice contiguous triangle all the way and then heading back. So there's a clear vertical cleft here of the lateral meniscus. That's again another pointer that there's something going on, which is multi-ligamentous, which is a sort of a twisting mechanism fit injury. Okay, so we've already confirmed one finding. We've already suspicious of a ACL tear, and we keep moving centrally. And as I keep moving centrally, I will still look at this, at the back of this particular aspect of the lateral tibial plateau, because you don't want to miss a fracture here. If you miss a fracture here, then it'll have long-term posterolateral pain associated with it. So of course, I can't see any obvious fracture, but I wouldn't rule it out at this stage, because remember, we've still got T1 to look at, and fractures are better picked up on T1. Of course, this is just a guide to tell you that there is something going on in the bone. So keep going centrally, and what do you see here? Well, clearly there is an abnormal signal intensity. As you very rightly said, you initially thought it was a sprain because there was abnormal signal. Remember the anteromedial and the posterolateral bundle of the ACL. But the problem here is more than just high signal. Although the orientation of the ligament is well maintained, there's something not right at the tibial footplate. Now, you did allude to it. You said that there was a bit of marrow edema here. But in addition to the marrow edema, look at the shape of the fibers of the ACL. Why is it curving around? It shouldn't be. It should be a nice taut structure. And all of the edema is centered here. So you can't really make out, but I would be really suspicious that there's something going on at the bony footplate. In other words, an avulsion fracture is what I would be thinking of, the tibial component, not the femoral component, because the femoral component, actually, you can still see parallel to the
Blumensaat's line, which is the roof of the intercondylar notch. So the problem seems to be here, but of course, we will confirm all of this. You can see that here. Now, whilst we're looking at that, why don't we look at the coronal, because we've got it there on the screen. We might as well just have a quick look at the coronal. And this intercondylar eminence of the tibia does not look normal, because there should be a nice sharp margins of the tibial spines in the intercondylar notch, and all of this marrow edema needs to be looked at. And we will look at the T1 in a second. So here goes the ACL, and you can see that there is lots of edema. Now that brings us, whilst we're looking here, so ACL, we're highly suspicious that there is an underlying avulsion fracture of the foot plate, or at least a full thickness tear of the tibial foot plate of the ACL. The next structure, whilst in the intercondylar notch, I would look at is the PCL. And why? Because of two important reasons. One, I would like to look at the shape of the PCL. Is it a nice, smooth, convex shape, or is it like this? Is it a hook shape of the PCL, which is what we call the shepherd's crook deformity? In other words, this is buckling of the PCL. So that, again, gives you a very good indication that there is an abnormal ACL. So if you look at the structure, the PCL, normally the PCL is black on all sequences. It doesn't matter whether you're looking at the PD, whether you're looking at the T2, T1, it's always black on all sequences. Why is it gray? That's not right. So which means that this ligament is also damaged. Of course, it's not torn because it still maintains its femoral attachment, tibial attachment, but it's got an abnormal signal, which means it may have a partial intrasubstance tear. And again, if you look at the coronal, this is the PCL. And if you look at the coronal sequence, it should be nice and black. You should see a round black structure lying in the intercondylar notch. If you see a gray structure, as you're seeing here, that's no good. That means that there is an intrasubstance abnormality of the PCL. So you've already, even halfway through the knee, you haven't even gone towards the medial side. You've already picked up an ACL avulsion tear. You've picked up a partial intrasubstance PCL tear. You've already picked up a vertical cleft tear of the body of the lateral meniscus. You've already picked up the bone bruising. Now, another important thing that whenever I look at the PCL, I would immediately, even if there's a hint of partial tear, I'd look at the posterior joint capsule, and I would look at the popliteal vessels, because if there's any damage to the PCL, the posterior joint capsule gets damaged, you get transection, or you get injury or dissection of the popliteal artery. So if normally we would say look at the flow void, but of course this is a PD sequence, so you'll see the vessels to be bright. So you look at these vessels and to see if the outline is normal, if the flow is nice and homogeneous throughout. But that's for more for PCL. Here we are more suspicious of a complete ACL and some PCL injury. We keep going now towards the medial side. So again, you can see as we come towards the medial side, this is the root of the posterior horn, the medial meniscus, with Dr. Budway elegantly demonstrated. And as we come peripherally towards, you can see that there is bone marrow edema, as you pointed out, of the posteromedial tibial corner and the medial femoral condyle. Why is this important? Posteromedial tibial corner. This is really important because this generally implies, if you see marrow edema here, I always think, is there a small peripheral tear of the posterior horn of the medial meniscus at its junction with the meniscal body? Now, I'm not entirely convinced it is there, but I would normally be suspicious. So I would look harder on the coronal sequence at the same time to see what's happening with the peripheral meniscocapsular junction of the posterior horn and the medial meniscus. Now, there's a bit of high signal. I'm not entirely convinced this is real or not, but a ramp tear this is the area where you look for a ramp tear. Now, a ramp tear is a sort of a vertical tear of the junction of the body with the posterior horn or the capsule. And this is generally what happens is because of the mechanism of injury, this meniscus pops out, hits the back of the tibia, goes back in. And as it does this, it causes a vertical cleft tear. So in any case, we will look at it. I haven't convincingly seen any. So on the medial side, but we picked up the bone contusion. So that's your sagittal PD done. And that's pretty much answered almost all of your findings. Almost, I said, not all of them.
because there's one thing left in this twisting mechanism of injury, as you would have heard in the lecture. Of course, I joined a little later, but whenever there is twisting injury, there is the risk of damage to the central core structures, which is of course the ACL and PCL. There's a risk of damage to the posterolateral corner and the lateral meniscus. There's a risk of damage to the medial meniscus, but there's one other thing which is left, which is also at risk, which you can't really see on the sagittal, which is the medial collateral ligament. So we need to look at the medial collateral ligament, and for that we have to go to either axial or the coronal sequence. So let's go to the coronal, which is already there. So let's just look at that. So the first thing which catches my eye is that there is lots of edema and thickening of the superficial MCL. Remember, this MCL has got multiple parts, 3 parts. This is the superficial part. Normally it should be a thin black line. You can see it's not thin, it's at least 2 millimeters thick. There is edema on the deep surface. There's also edema on the superficial surface. This gray structure is called the meniscofemoral component of the deep MCL, which always gets damaged, especially in a twisting injury. So you can see it's not a thin black line like here, which is the meniscotibial component. Remember, of the two, whenever you're seeing knee, the chance of damage is highly likely to the meniscofemoral, very less likely to the meniscotibial. So you can see the meniscotibial is nice and beautiful, nice black line, but this is gray and thickened. So you've already ascertained that there is damage to the MCL. Of course, it hasn't disrupted. So a different grading system, you don't have to remember, but if it's only stretched and edematous, it's grade 1. If the fibers are partially torn, or if there is some disruption of the fibers, you call it grade 2. And if there's complete avulsion, you call it grade 3. So here you can clearly see there is no avulsion. There is no disruption of the fibers, but it's just edematous and thickened. So clearly this ligament is sprained, or we call it a grade 1 injury, if you want to call it. You can see the tibial attachment. You can see the tibial attachment. Remember, it goes way down, almost 5 centimeters or 7 centimeters below the medial joint line. So we pretty much answered all the questions. Do we need to look at any other sequence? Yes, we do need to look at other sequences. And I'm just going to bring a T1 weighted sequence up here. Why? Because we want to see if there is a fracture or not. So let's start again from the lateral side. Now here, I'm only interested in fracture. I'm not interested in anything else. So it is this area that I'm slightly concerned about on the T1. Can you see that little step here? And let's go to the midline, where we are very suspicious that there is something going on here, because this is not the normal shape of the intercondylar eminence. So we are suspicious on CT, on MR, that there is a problem. So normally what would I do? I would recommend that this patient have a CT. And the reason why it's important for them to have a CT is that we want to see if there's an avulsion fracture, because it may require fixation. But before I go and start asking for a CT, I just want to have a quick look at the axial sequence. Now, the axial sequence is really important for multiple reasons. You've already on the sagittal seen all the central bits, but what you haven't seen is what's happening at the front of the knee. And the front of the knee is a whole separate structure called the extensor mechanism, or the extensor apparatus. Now, the extensor mechanism is this quadriceps, the patella tendon itself, and of course we look at the cartilage at the patellar surface and the femoral trochlea. So if I quickly run through it, I know we push for time, you can see the cartilage is nice and smooth, so there's no chondromalaysia patelli change, but I can certainly confirm the MCL attachment of the femoral attachment of the MCL. So that's really gone, or in other words, not gone, but edematous. So that's damaged. You can see the ACL in there, you can see the PCL in there. It'll actually give you a lot of information. And this is where the problem is, which we think is probably an avulsion fracture. So normally, when I look at the axial, in addition to chondromalaysia patelli and all the patellar maltracking that Dr. Sajid Bhatt mentioned to you, I would also look for any joint effusion, which you don't see here. On the sagittal, I would quickly cast an eye at the superlateral margin of the Hoffer's fat pad to see if there's any impingement. And also, I would look at the back of the knee to see if there's any popliteal or Baker's cyst. And of course, I would normally look at the popliteus tendon, because this usually gets damaged or edematous in ACL and PCL injuries. So axial is very good for looking at the ligaments on the side, the front and back. And of course, you can see the popliteal vessels flow void. So we pretty much in 5 minutes or 6 minutes looked at all the structures. I always follow the same sequence. From lateral to medial, bring the coronal up, cross-reference on the coronal, bring the axial up, bring the T1 up to exclude fractures, axial to look at the extensor mechanism, chondromalacia, patella changes, and back of the knee to look for any Baker's cyst. So in order to confirm, we have to look at the CT. I've just stopped sharing because I need to bring up the CT of this patient. Oh, hang on. Share. So this was, okay, I'm just going to bring this up. I'm going to stop share and then reshare again to see if you can actually see the CT. Okay, this is the CT of the same patient. Let's just go from the lateral to the medial side. What catches your eye immediately is that there is a bone fragment there. There is a step deformity here. So this is a non-displaced fracture of the posterolateral tibial plateau. There is an avulsion fracture, which is a bone fragment sitting at the back. And of course, as you go towards the middle, voila, there is the avulsion fracture of the tibial footplate of the ACL. Now, the question is it really acute or is it subacute? I think it's probably subacute for the reason that there is no joint effusion. It's highly unlikely you fractured something and there's not a hint of any significant effusion. There is not a hint of lipema arthrosis, as we would expect there to be. So there's probably an acute on chronic. The ACL may well have been damaged previously, but the patient has had a twisting injury. That's why he's got the bone bruising on the lateral side. He's torn he's got a cleft there of the lateral meniscus, and he's damaged the MCL, which we know is acute because there's lots of edema. So this is how I would attempt. And in my summary, I would say to the examiner, the appearances would be consistent with an avulsion fracture of the ACL, which may well be long-standing because there's no joint effusion. However, there is an acute element which involves edema of the MCL, which is a grade 1 sprain, and bone marrow edema at the lateral femoral condyle and the posterolateral tibial corner, with an associated vertical cleft here of the lateral meniscus. So this is more like an acute and chronic picture. End of story. So you need to summarize at the end, as you did. I did notice that you did bring a summary to us as to how you would attempt it. So I think that's the first case. I'm going to stop sharing. And
Babar, can we go to candidate 2? So
correct.
Babar, don't worry about, should I say, quantity. I always say quantity is not important, quality. And the way I think everybody learns so much from this single case. So even if the last candidate 2 is our last candidate, even she sees one case or two cases, the quality which you are giving, that is brilliant.
Excellent, fine. We will carry on with candidate number 2 this time. So I'm just going to first share and then give the control to candidate 2. So I'm going to share.
Thank you, candidate 1.
Yes, that was very good. Well done.
Thanks.
Remote control. Right, here you go, candidate 2. You've got the control. And can you just confirm that you have the control? Yes, you do. I've brought up the same sequences. So this is a 26-year-old, again, with a similar sort of twisting mechanism of injury. And the case is all yours.
So on this PV fat set sequence MRI of the knee, looking at the sagittal lateral compartment, there is significant bone marrow edema in the lateral femoral condyle and a new joint effusion. So it's a bit lagging, so I'm just still scrolling slowly.
Can I add this patient had a motorbike accident?
The lateral meniscus is intact with normal morphology. And the ACL fibers appear intact. there is a tear in the posterior cruciate ligament at the femoral attachment, which is a complete tear. The medial meniscus appears normal on the, appears extruded anteriorly, but I don't see a tear at the moment. There's no significant bone edema in the patella, so I would like to proceed with the coronal sequence. So starting from lateral, the bicep femoris tendon and appears intact.
Can you point out for the clarity of the people watching? Excellent, very good.
There is abnormal signal in the lateral collateral ligament,
Just point
which I can't hear. I wonder if that's part of the capsule. I'm trying to distinguish that from the lateral collateral ligament. So actually, I think the lateral collateral ligament is probably okay. So that's probably just the capsule. So again, the torn PCL is noted, and there is, I mean, the menisci is normal other than slight extrusion, which may be related to posterior displacement of the tibia. The medial collateral ligament is torn and with significant soft tissue swelling around it. I would like to also assess the knee on the T1 and the axial PD flat set sequence. But I can summarize the findings.
please.
Okay, so there's a complete PCL tear with lateral femoral condyle bone contusion with knee joint effusion. So this is in keeping with a dashboard injury with a complete PCL tear.
Okay, so we'll take the remote control back. Well done. So in summary, it was a dashboard injury with rupture of the PCL. So good, you did very well in the sense that you quickly picked up the things that I've just noted on the previous MR. So you're sort of going through the same routine, which is excellent. However, if somebody had a dashboard injury, where would you expect the contusion to be? What does dashboard mean?
Usually that would be patellar bone marrow edema with the anterior tibial.
Probably not. And the reason for that is, remember, when you're sitting in the car, your knee is flexed. So the patella is way out of the way, sitting at the top. It's your tibia, which is sitting right at the front, which is going to take the brunt, because that's the bone which hits the dashboard. So if somebody gets a dashboard injury, this is where the bone contusion and bone marrow edema is going to be. Not at the patella, definitely not at the lateral femoral condyle, which is what you have, because that's the first thing which strikes me. When I start with my routine, remember I said I start with the lateral collateral ligament conjoint. Now here's your lateral collateral ligament. You can see it beautifully here, coming at an angle joining the biceps femoris, forming the conjoint insertion. So actually this, the first sagittal gives you a beautiful view of the lateral collateral ligament. Now let's just confirm the lateral before we go anywhere. So this that you were probably mentioning is a very important point, because remember, you're only seeing part of the attachment here. There's still a little bit at the front that you're not seeing, because remember, it's a curving bone. So you may well be right that there is a little bit of high signal at the femoral attachment, which I wouldn't be surprised. Look at the huge amount of bone marrow edema at the lateral femoral contour. So the most important thing for you to understand, can I ask you, if it's not a dashboard mechanism, what else could it be? What else could be the mechanism?
Pivot shift.
Okay, pivot shift is rotation. This is an impact on the lateral side of the knee. Why? Because all the marrow edema is centered at the lateral. So there's been an impact at this side of the knee. Remember, wherever you get the impact, you get massive bone bruising. On the opposite side, you get less bone bruising. And imagine if the force was coming from the lateral to the medial side, you'd get bone bruising here, but you will disrupt the MCL. Because remember, when the two bones are like this, if the force comes from outside, it'll open up the other side of the bone. So it'll open up this side of the joint. When this side of the joint opens up, you damage your MCL. So that's the classic lateral to medial force vector, which is acting on the knee joint. That's why you've got this pattern. This is classical pattern. Force is coming from here, lots of bone marrow edema here, less bone marrow edema here, but at the same time damaging the MCL. So because this joint has actually opened up and closed again. And that's why you don't see the opening up, but you've definitely now noticed the sequelae of the injury, which is the complete disruption of the MCL. So on the first, as I would normally start, if I just see lots of bone bruising of the lateral femoral condyle, I know this is an impact injury. It's not a twisting injury, for the simple reason that there is no bone bruising at the posterolateral tibial corner. So this patient has had an impact on the tibia, so on the femur. So let's follow our routine. So we've seen the biceps femoris, we've seen the lateral side with no bone bruising here, but lots of bone bruising there. And of course, we start looking at the lateral meniscus. So the lateral meniscus seems okay on the sagittal, but we can't be sure because we still have a coronal to look at. So let's just go through the coronal very slowly. We're starting at the front of the joint. And as we head back, we start seeing a nice triangle. Triangle. Is it still a triangle? Not really, because there is a little bit of blunting here. So remember, you may not see this bit of the tear on the sagittal because it's on the other side. It's exactly here. So there is a small blunting. It should be a nice triangle, but there is a little blunting here. So I would say that this is there. If you're not absolutely committed, you just say there's blunting of the inner tree margin of the body of the lateral meniscus, which may suggest that there is a small radial tear of the inner tree margin. So I would definitely make a comment, even if it's a negative or positive, make a comment, tell the examiner that you've seen this. You keep going back and the posterior horn looks beautiful, so there's nothing there. So we picked up two things. Let's keep going towards the center. The first structure that you will see is the ACL. So remember the anteromedial and the posterolateral. The ACL is definitely intact, but there may be some intra-substance signal. I would take it either ways. If you say there's a little bit of edema, I wouldn't critique you on that. I would say fine. But the ligament generally seems intact. The problem, as you very rightly say, is the PCL. Why? Because remember, it's not following the rule. It has to be black. It's not black. Not only is it not black, is it contiguous? No, it's not, because there's a disruption. So remember, the PCL has got different parts. It's got the femoral attachment, it's got the genu, and it's got the tibial attachment. So the genu and the femoral attachment is abnormal because there is abnormal signal and there is a discontinuity here. Let's confirm that immediately on the coronal. Is that a normal shape or signal of the PCL? And the answer is no. And the more you come forward, you see there is a gap here, which means it's complete. There should be a nice round black PCL looking at you at this particular slice. And you don't see that. What you see is a white structure, some black fragments,
clearly implying that there is a complete disruption of the PCL. Remember the things I said to you. What do you do next when you look at the PCL? The most important thing you look for? Sorry?
The popliteal vessels.
Correct. So you have to look at the popliteal vessels. You have to look at the posterior joint capsule. Tell me what you see. Look at the posterior joint capsule. That's abnormal. It's diffusely thickened. It's diffusely edematous. This should be a nice margin that you should be able to pick up with your cursor. You don't. So that means that there is damage to the posterolateral joint capsule. But the good thing is the vessel looks pretty good. Why? Because the mechanism of injury is not front to back. It's medial to it's lateral to medial. If it was coming, if the force was coming from this direction, you could easily damage your popliteal vessels. But here they're saved because the vector is coming in the transverse plane. So it's coming from the wrong side. So there's no danger to the popliteal vessels here. But of course, it has disrupted the PCL. Now, the only question is there any avulsion of the bone? And the answer is no, because you can still see the black cortical margins. If there was an acute avulsion, there would have been lots of marrow edema of the site of attachment. So clearly that is not the case. So you keep going medially now. So you start seeing the root of the posterior horn, the medial meniscus. You look at the medial meniscus all the way, you confirm the medial meniscus. You can clearly see there's a bit of myxoid degeneration because there's clearly abnormal signal, but it's all centered within the meniscus. It's not going to the articular surface, so you cannot call it a tear. You can certainly call it myxoid degeneration if you want. And of course, why is the meniscus extruded? You kept mentioning that the meniscus seems to be extruded out of the joint, or at least anteriorly. And there's a very good reason why you should be able to justify that statement. Because remember, the meniscus is held in its place by the MCL. MCL has got the meniscofemoral, the meniscotibial components, the superficial. Should have kept some water here. So you can see, because this, the MCL, which also holds the meniscus, is not there anymore. It's completely disrupted. As a result, the meniscus extrudes. So that was a very important finding that you picked up, that the meniscus is extruded. But of course, the examiner may say, why do you think the meniscus is extruded? So you've got to explain. So whilst we are here, let's start looking at this MCL. What's going on with the MCL? So you see the tibial attachment. That's how it should be. Nice. But it starts to get edematous and thicken, and here it disrupts. So it almost disrupts at the level of the meniscus. And then at the femoral attachment, there's nothing there except for, it's just like a mince. There's hardly any fibers attached. I can't distinguish between the superficial and deep MCL. So I need to now bring up the axial on the other side because I want to look at this meniscus. Because remember, this is not, I need to look at the MCL because remember, it's not just the MCL which attaches here. What else attaches? The medial patellofemoral ligament. So the medial patellofemoral ligament, if I bring it up here on the axial, let's go up, is this structure which connects the medial femoral condyle to the medial patelloretinaculum. Remember that all of this is not the medial patelloretinaculum. It's only the part which attaches to the medial half of the patella is the medial patelloretinaculum. Beyond this, all of this is the MPFL, or the medial patellofemoral ligament, as the name implies. And the medial patellofemoral ligament has got a conjoint insertion with the MCL. So when the MCL completely disrupts, it damages the MPFL as well. So that's why you see it's all edematous, it's all thickened. So you've damaged the entire medial support of the knee now. So this knee is unstable. And this knee is unstable because there's nothing on the medial side protecting it. All of it is disrupted. And of course, the patient is lucky because the patella has not gone all the way on the other side because there are probably still medial patelloretinaculum fibers holding it because the MPFL is not completely torn, it's partially torn. So immediately you can see, just bringing the three sequences, you've pretty much managed the whole case. You've picked up all the findings, you've understood the mechanism of injury, how this has happened. Because it's, remember, if you understand the mechanism, you'll pick up the relevant structures which are going to be damaged. Just in your mind, imagine what will happen to the structures that the force comes from outside. Now, if I was to reverse the force, if the force was coming from the inside of the knee, You will have lots of bone bruising here, very little bone bruising here, but you will disrupt the biceps femoris and the lateral collateral. And the typical mechanism is that the biceps femoris avulses from here because the lateral side of the knee opens up. So it's exactly the opposite of what you're looking at if the force was to come from the medial side. And of course, this is an acute injury for multiple reasons. There is bone bruising, there is lots of joint effusion. So there is a moderate joint effusion there. And of course, you've looked at the popliteal fossa. There is a little bit of edema here. Remember, the pes and serranus tendons are intact. So is the tibial attachment of the ligament. It's the femoral attachment. So what would I say in conclusion? In conclusion, I would say to the examiner, there is significant bone bruising of the lateral femoral condyle, implying an impact site of the injury. And as a result, there's disruption. There is a grade 3 complete, if you don't want to use the word grade 3, use complete disruption of the femoral attachment of the MCL, resulting in extrusion of the medial meniscus. It has also damaged the medial patellofemoral ligament, which is edematous and thickened, but not completely torn. And there is no patella dislocation. This is a relevant negative that you're giving, that there's no patella dislocation. And most importantly, there is complete disruption of the PCL. So how do you treat PCL disruptions? Generally speaking, they, unless it's a bony avulsion, they tend to heal. So it's unlike ACL where you have to go in and do intervention. This generally tends to heal and scars and actually functions pretty well. But if it's an avulsion injury, then you have to go and fix that. Okay. So that's case 2. Have you got time for one more case?
Yes, please. We'll go for one more case. And all of the audience, you know, for your FRCR 2B exam, trauma cases are very popular. So whatever is being taught, this is classical cases, and they come as a long case usually. So multiple findings in trauma cases are the most usual knee MR. So Babar, very useful. Please take another. And even if you go slightly beyond 9, this is gold dust. So please continue. Take your time for one more case.
So I'll probably show you 2 short cases. We'll
Okay.
keep, so each candidate gets another chance. So I will let me just bring up the case first.
So you want to take candidate 1 once again?
No,
Candidate 1, are you with us, please? Are you with us, candidate 1?
Yep.
Your case, please.
Okay, let me just bring it up. And I'm going to give you the control. Have you got it?
Yep.
Excellent. So here's another young man, and the interesting story here is that this is definitely a skiing injury.
Okay. So starting with the PD sagittal sequence. So I can see the conjoint tendon normally.
Can you point out?
So
I think we're on the medial side of the knee.
Oh.
That's okay. We've done this all so many times. There you are.
All right, so starting with the lateral side. Yeah, sorry. So that's the bunny sign of the conjoint tendons. Yep. So going laterally first. So there is significant bony contusion on the lateral femoral condyle. The tibia and fibula are preserved. There's no evidence of meridema there. Just having a closer look at the lateral meniscus as well. So I'm concerned about the posterior horn of the lateral meniscus because it's significantly smaller than the anterior horn. But I've not seen any evidence of an obvious tear yet, but I'm just going to have a closer look again. So there is high signal coming from the anterior horn of the lateral meniscus.
Is that what Dr. Butt mentioned to you? Remember, he mentioned a very important point about the anterior horn of the lateral meniscus.
Yes, I believe he said that if you see a meniscal cyst, ganglionic cyst, which I think that is what that is, you should be looking very closely for a tear. But additionally, you can get fluffy appearances of the meniscus, which is normal.
Mm-hmm.
So I think this is normal. It's just a ganglionic cyst in that region. Just going through the rest of the image. Okay, so there is a joint effusion and just trying to see the ACL. I can see that the ACL is intact, but there is significant marrow edema and soft tissue around the entire knee joint. So there is also bony contusion on the posterior aspect of the femoral condyle. Just trying to see the PCL. Apologies, it's just a bit slow.
Yeah, understood. It is a bit slow.
So the PCL looks intact. It's uniformly dark. Although the the femoral attachment, there appears to be discontinuity of the fibers there, but I'm just going to have another look at it. Yeah, so I'm concerned about the femoral attachment site of the PCL. Just going to, so yes, again, large joint effusion. And looking at the medial meniscus, that looks intact, although there is some high signal within the posterior horn, but again, it doesn't seem to be in contact with the articular surfaces, so I don't think it's a tear. I think it just might be some mucoid degeneration. Okay. So in essence, there is some meroedema on the posterior aspect of the femoral condyle, and I believe there's an abnormality at the femoral attachment site of the PCL as well. So I'm just going to look at the coronal sequences now as well. So specifically looking at the PCL on the coronal view to see if it's normal. So the PCL looks fine actually because it's rounded and it's dark. Okay. So again, there is a cystic structure arising from the lateral knee joint, which I think we already established is a ganglionic cyst, and there was no evidence of a meniscal tear in that region. So I'm just trying to work out. So there is a significant meroedema along the lateral femoral condyle. So I believe this is in keeping with a direct impaction injury, as opposed to a twisting injury. And you mentioned that the patient's a skier, so I'll be worried about a pivot injury, pivot shift injury, although that's more of a twisting.
A pivot shift injury?
Yes.
Suggest the ACL doesn't look, you've said the ACL looks fine, you've said the menisci look fine, you haven't said it, but you haven't said anything negative about the MCL. So how can it be a pivot shift if none of these structures is damaged? Just because he's a skier, poor thing, doesn't mean that he's going to end up with a pivot shift.
Yes.
Most likely, but then you've got to give me a proof of the pivot shift injury resulting in structural damage, which you haven't.
Sorry.
We can go back and can you see a little orange revert button? If you press that, it'll go back to normal. Yeah, that one. Reset. Top left.
This one?
Oh, hang on. Here you go. Oops, that's disappeared.
Sorry.
Oh, that's okay. Okay, give us a summary then, apart from pivot shift. Any other thoughts?
I'm just thinking of the normal contusion patterns. I mean, I'm a bit confused because there's significant marrow edema, but I've not seen any meniscal injuries or the ACL is intact. The PCL, I believe.
Sorry to barge in. We have lost your screen. Okay, it's back now. So please continue, candidate one. Please continue.
Sorry, I'm just trying to make sense of the findings.
That's fine. Sometimes in the exam situation, you can't make sense of things. That's absolutely understandable. So if you are stuck in a situation, you say to the examiner, these are my findings. I'm sorry, I can't really understand the mechanism. One of the possibilities is, as you've said, that there may well be a direct traumatic injury to the lateral side. That's absolutely fine. You know, there's only limited time and you can't be expected to give a full mechanism of injury. If you do, that's excellent. You only get extra marks. But let's just go through the case again. Let's go back to the lateral side. And we start with this particular image where you actually beautifully see the common peroneal nerve. Can you see that? So that's the normal course of the common peroneal nerve around the fibula neck. So, and sometimes if you damage the fibula, you can damage the nerve. This is the biceps femoris. There's a bit of high signal, but still seems nice and intact. The lateral collateral ligament seems intact. So you've got the Bugs Bunny, as you said. Now, all of this abnormality, what is the chance of me showing you two lateral contusion back to back? Zero. There's no way I'm going to show you exactly the same case again. So that means there must be, let's just keep looking. The lateral meniscus, you said, is abnormal initially because you thought the posterior horn was significantly smaller than the anterior horn. If you look at the anterior and posterior horn, there's not a huge amount of difference between the two. And remember, I always said, just correlate with the coronal as well. And you can see actually the lateral meniscus looks pretty good. Remember the last case I showed you where there was blunting? Look here, the triangle is maintained front to back. So the lateral meniscus is absolutely fine, as you very rightly said. We keep going forwards. And as we are going forwards, can you see that there is additional bone bruising? There's additional bone bruising coming in view where? Patella. You keep going, look at the bone bruising here. So that should immediately alert you to only one particular diagnosis. Whenever you see marrow edema of the lateral femoral condyle or lateral femoral trochlea, and you see corresponding marrow edema of the patella, you start thinking about transient lateral patellar dislocation, even without the axial. You haven't even looked at the axial yet, but if I see marrow edema of the patella, I see marrow edema of the lateral femoral trochlea or the lateral femoral condyle, the first thing which comes to my mind is a transient lateral patellar dislocation. So we need to now look at the case with this extra finding that we picked up, which is all of this. And remember, there's also something else which is not right. It is the shape of the patella here. It seems rather blunted. It should have an apex going all the way through. There's a bit of something abnormal visible here, but we'll confirm that once we look at the axial. So remember, now we are heading towards the medial side and you still see marrow edema. So that should immediately put you into a firm diagnosis that this is going to be a transient lateral patellar dislocation. So how do we confirm to see what else is going on? You also see that there is a little cortical break here. See, the cortex is generally black on almost all sequences, but if you see the cortex stops here, so you need to be careful as to what's going on here. So let's just keep looking. I completely agree with you that the ACL looks fine. And I also agree the PCL looks fine and the posterior joint capsule looks okay. The medial meniscus shows myxoid degeneration, as you very rightly said, because you've got the coronal sequence to look at and there's convincingly no tear visible. You do see that there is a bit of myxoid degeneration. You've already
we've already said that the MCL is generally visible as a thin black line on the coronal. You can see that. There's no, remember there's a bit of joint effusion, so you will see a little bit of fluid in the recess, but it's nothing major. This is just part of the joint effusion which is visible. What's interesting about the joint effusion is what I want you to look at. Can you not see that there is a level here? There's a difference in the signal intensity of this fluid and this fluid because there's a vertical line, there's a horizontal line running through. Can you see it better now?
Yes.
This is lipohemarthrosis, as you call it. This is a fat fluid level, implying that there's been a fracture, or at least there's some fracture somewhere. We don't know where yet. We just know that there is a fracture, and we are concerned about the patella. So we've confirmed that the menisci generally look okay, the cruciates generally look okay, the patella doesn't look right, and the lateral femoral condyle doesn't look right. We need to see the axial sequence now to see what's going on. Bring up the axial sequence, and that confirms your fat fluid level, lipohemarthrosis, and here goes your transient lateral patellar dislocation. So this patella has actually gone, hit it here, come back, fractured the medial half of the patella. Look at the medial patellar retinaculum. It's diffusely thickened. This is how it should be. This is the lateral patellar retinaculum. This is a thin black line. You should have a similar sort of thing here. But what you see is diffuse edema, diffuse thickening of the lateral and the medial patellar retinaculum. So you have to now follow the medial patellar femoral ligament. Remember, I was telling you medial patellar femoral ligament. So this is part of the medial patellar femoral ligament, which actually doesn't look too bad, which is actually intact. But it's the medial patellar retinaculum which is torn. Now, what else happens when you transiently dislocate the patella? You sometimes can disrupt the cartilage, and most commonly the cartilage goes from here, because as the patella slides across, it degloves the cartilage from here and takes a piece of the cartilage, which is torn off. Or where the patella apex hit the bone, that's where most of the damage is. So what you can see here is that this cartilage is abnormal. See the black line? That's the cortex. Where is the black line here? You don't see it. And then you see the black line here again, which is the cortex. So there's definitely been an avulsion or some sort of bony injury of the patella apex with damage to the cartilage. And that's why you've got the fat fluid level. So what do? We need to find where the fracture is. What would you do?
Look at the T1s. Oh, sorry. Do a CT.
Do a CT, absolutely. Simple answer. Even if you do a T1, you wouldn't be able to be absolutely 100% sure. Do a CT is the correct answer in the exam situation. I've actually got a better is my screen still sharing or not?
No. So.
No. Okay, here you go. This is the X-ray of the same patient. Can you see a fractured fragment?
Yep.
So sometimes plain X-rays are really important because with this sort of injury, you can actually see an avulsed fragment already visible. And this is the fat fluid level that you can see. So CT is the correct answer, and you would have gotten full marks for that. So remember, I've shown you 3 different patterns of bone marrow edema, completely different mechanisms of injury, completely different things to consider and think in your mind. Just by looking at the pattern of bone bruising, you've actually reached the potentially reached the answer as to what would have happened, because then you'd be able to tell the examiner what are the structures which get damaged. If you don't pick up the marrow edema of the patella, you'll never tell them that this is a transient lateral patellar dislocation. You'll never tell them that there's damage to the medial patellar retinaculum. You'll not tell them that there is an associated fracture or cartilage damage to the patella. Is that okay?
Yeah, that's excellent. Thank you very much.
Okay, stop sharing. Last short case for candidate number 2, and then we're done. I don't know about you because I've had it. So we'll go to, here we go. I'm going to get candidate 2 now. I'm going to share the screen first.
बिजनेस से बेहतर था जॉब ही करता रहता
Remote control. Candidate 2 still there?
Yes.
There you are. So this is a middle-aged person, about 45 years of age, and was playing excellent golf, but then suddenly presented with swelling and pain in the knee and could not continue beyond the second hole.
Okay, so on the sagittal PV fat set sequence, I'm looking at the lateral compartment and the bicep femoris and lateral collateral ligament tendons appear intact. The quadricep tendon is abnormal, and there appears to be tear in the muscle with a large joint effusion. Just look at the patella. There's no bone marrow edema of the patella. The lateral meniscus is normal. I'm just looking at the ACL. The ACL and PCL appears intact. So the medial meniscus is abnormal. There's cannot see at least two bow tie, which suggests there may be a bucket handle injury. And the posterior horn of the medial meniscus is also truncated, as well as that the proximal tibia, where the posterior horn is attached, is abnormal. There appears to be maybe a fracture fragment, but it's very difficult to characterize on the PD fat set. So I'll look at that on the T1 if that's available later. And there's more joint effusion posteriorly with the capsule looks distended and swollen, and the popliteal vessels appear normal. So I'll look at the coronal view now. I'll start anteriorly. There's some high signal in the medial tibial plateau with a fracture fragment. And the anterior horn of the medial meniscus is, that's okay. I'm trying to trace it back to posteriorly to confirm whether there was a bucket handle injury and to find the displaced fragment. Which is usually an intercondylar notch, but I'm not seeing it.
Okay, good.
I would like to look at the axial view just to confirm if there is quadricep tendon or muscle tear.
You've got the axial.
So there's significant high signal in the quadricep tendon, which is in keeping with a rupture.
Okay, so in summary,
there is a bucket and no injury of the medial meniscus and complete rupture of the quadricep tendon and a fracture fragment of the medial tibial plateau.
okay. Okay, good. So, so remember, you can get muscle injuries around the, or tendon injuries around the knee, which is very easy to miss, especially if they've done a very tight field of view images. Sometimes you may come across extremity scanners in which the field of view is round and it's quite limited. So generally speaking, if you've got a standard 1.5 Tesla machine, chances are that you would normally cover the distal quadriceps entirely easily. So there's no chance of missing that. So you're absolutely right. You picked this up very well, because there is a high-grade tear of the quadriceps tendon. Now, the important question is it a full thickness tear or a partial thickness tear? Because there are implications. If it's a full thickness tear, it requires surgical repair. If it's a partial thickness tear, it may just heal. So in your summary, you just cannot say that there is a tear. You have to quantify it one step more for the examiner or for your surgeon. If this was a case in your department, the first thing that the surgeon is going to ask you, do you think it's a full thickness tear or a partial thickness tear? Did I hear anything from you on those accounts?
I said full thickness, but not in the summary.
Now, are you sure it's a full thickness? Just looking at this, I can easily say to you, but I can still see some tendon fibers.
Other than that single tendon fiber, I think most of it is gone. So I would say this is high grade and
So now you're changing your diagnosis to a high grade partial thickness tear. Is that right?
Yes.
Or are you saying still a full thickness tear? The reason I'm asking you, I'm pestering you for a reason. The reason is sometimes we can't be sure on MR. You have to do an ultrasound exam. Ultrasound is really important for tendons, especially the extensor mechanism, because ultrasound is superb in picking up patella and quadriceps tendons disruption. If you were to do an ultrasound, you'd easily tell us if there is any fiber which is intact or not. Now, if there is a central fiber which is still intact, you may have actually disrupted the tendon on either side, but the central tendon is still holding the quadriceps at the superior pole of the patella. So they may just treat them conservatively. Remember, this is a middle-aged man. He's not going to go out and, if he was a footballer, they'd probably go in and repair it. But for somebody, why do you say I gave you the, even if you look at the medial compartment, even if I don't give you the age, this is not a young knee, is it? Because if you look at the compartments, just bring up the coronal on this side. So what you notice here is that this patient has got osteophytes. So on the medial side, there has been an ongoing degenerative process going on. So this is a long-standing, or this is not an acute tear, this is a degenerate tear. What sort of a tear? You didn't mention, did you mention what? Of course, just tear is one thing. Then you have to tell them, whenever you describe a tear, you have to tell them 3 or 4 things. First, is there a tear? What sort of the shape the tear is? Is it an oblique tear? Is it a radial tear? Is it a horizontal tear? Is it a complex tear having more than 1 bits? The third thing you've got to tell them, where is it? Is it at the front, the anterior horn? Is it at the junction of the anterior horn with the meniscal body? Is it the meniscal body itself? Is it the junction of the meniscal body with the posterior horn? Is it the root of the posterior horn of the medial meniscus? So all of these things, whenever you start describing a tear, you have to mention these 3 or 4 things, because the examiner will immediately know that you've looked at knee MR scans. You know what you're talking about. So if you look here, just on this particular sequence, this is a pretty abnormal shape of the medial meniscus. It's blunted, it's extruded, so it's definitely a degenerate radial tear of the body of the medial meniscus. The meniscal root is degenerate because you can see there is abnormal signal. Look at the root hair, nice and black. Look at the root hair, white or gray-white, which means that the root is degenerate. The tear involves the peripheral third of the posterior horn of the medial meniscus, because remember, this is the posterior horn. And as we come forwards, you can start seeing the anterior horn, which looks more okay. So the tear is primarily meniscal body and posterior horn junction.
And as a result, there's a bit of extrusion because of this radial tear. There's no bucket handle tear. For bucket handle, you need to see an extra fragment lying here, which you actually did mention that there wasn't. You could not see a bucket handle flip meniscal fragment. But most of the time, what happens is because the tear is here, the meniscus extrudes out. So this is a complex tear of the medial meniscus. And because of this extrusion, this irritates the deep MCL. This is called deep MCL synovitis. See, this is the superficial MCL. You see fluid in the deep MCL recess both around the meniscus above and below. This is quite typical of deep MCL synovitis. This causes constant pain to the patient. Even if the meniscus is repaired, if you don't do something about this, it will keep causing pain. So that then brings us to the quadriceps tendon. So quadriceps tendon repair ruptures, you must do an ultrasound. Because remember, it'll give you an idea as to whether the central bit of the tendon is involved, or is it the vastus lateralis and medialis which are coming in. Most often, you disrupt just one bit. Sometimes it's the vastus lateralis, sometimes it's the vastus medialis. Unless it's a transection injury, then you rupture the whole of the tendon. Just by twisting, it's very rare to rupture the whole of the quadriceps tendon. But you did extremely well because you picked it up. It's very easy to be bogged down by looking at these structures here that you don't actually look up here. So you did excellent to pick that up. So this is what this case was all about, for you to develop your eye to pick up the tendons, especially the quadriceps. So I think that's all I have to say today, Dr. Sunny.
Thank you very much. It was absolutely brilliant. And I am sure everybody enjoyed it. Everybody learned a lot.